Okay, Assalamu alaikum everyone. I hope you're all doing well. Inshallah, for today, we're going to do the lower GIT part of this crash course. As all of my sessions, inshallah, this will be interactive. I'll be going over everything that's important and high yield, inshallah, for your exam. Okay. So what we're going to be talking about today, inshallah, is the small and large bowel, which will be the majority of our session today. Then the appendix, just a bit about it. There's not a lot. Anorectal, again, same thing, and hernias. Okay. Now, for the session, I'm going to go over the basics of each and every one of the 4 points that I talked about. And then the pathologies and management and treatment. If there's pharmacology, I'll cover it as well. Okay. So let's start with the bowels. So for anatomy, there's not a lot for you guys to know, but we'll start from here. The duodenum has 4 parts, as you guys know, and the parts that I need you guys to be very good with are these. This is the second part, and this is the third part. The second part, the significant thing about the second part is the opening of the sphincter of Oddi, which should be around over here. Why is this important? Is the bile duct, the common bile duct, and the pancreatic duct will join together at the ampulla of Vater and will go into the duodenum through the sphincter of Oddi. So if you have a mass or a diverticulum that's intramural, that's obstructing this sphincter of Oddi and this ampulla, this will cause, obviously, pancreatitis and bile stasis, which can cause acute cholangitis, which we'll get to that, inshallah, after Eid, inshallah, okay, for the liver and pancreas. So that's a significant part of this, okay? As well as if you have anything that's obstructing this area, you will have decreased pancreatic secretions that's going into the bowel, which will cause steatorrhea and fat malabsorption. Okay, that's the other significant thing about it. The next part is this part over here, which is a transverse part of the duodenum. This part over here is the third part. The important thing about it is there's an artery that will go anterior to this part. Do you guys know what artery this is? Exactly. This is the superior mesenteric artery. Why is this important? Is there's a certain disease that can cause a small bowel obstruction, and we'll get to that later. But just remember this relationship, okay? The rest of the bowel is not too important to remember the details of, the anatomy of it. Just, the small bowel is smaller than the large bowel. That's how you can tell it in terms of radiology. There's no haustration, which is what this is. Okay, in the large bowel, the ileocecal valve is over here, which connects to the cecum. And then the other part, which we'll go over in both the large and small bowel, is the mesentery, okay? Now, the mesentery will have the blood supply of the bowels going into the walls of the bowel. Okay, it carries it basically. Now, this side of the bowel, which is connected to the mesentery, is what we call the mesenteric border, okay, or the mesenteric side. Here you have small little blood vessels, which is what we call vasa recta, going into the walls of the bowel. This part of the bowel is the weakest site of the bowel, okay? Where you have the vasa recta going into the walls. This is the weakest portion of the bowel in both the large and small intestine, okay? Why is this important clinically? Is because diverticula, if it were to form, it usually forms on that side, okay? And we'll get to that detail, inshallah, later on. For the large bowel, there's not too much other than that. The only other thing I want to talk about in terms of or two things. Firstly is the Taenia coli, what's important about that, which is basically it all joins together at the base of the cecum. There's 3 Taenia coli. It all joins together to form the base of the appendix. So that's how we can find the appendix. Small little clinical detail, okay? The other thing, just for the concept's sake, is the sigmoid colon. The narrowest in terms of the lumen in the entire colon is the sigmoid colon. Why is this important? If this portion of the bowel is already very narrow, okay, if you have a mass or an obstruction here, or mass or a polyp, okay, it usually will cause obstruction, okay, or more commonly can cause constipation, changes to the stool consistency, it becomes like a pencil-shaped stool. This is important for cancer, okay? Because there's differences between cancers of the left side of the colon and the right side of the colon. The left-sided, which is where the sigmoid is, which is the most common site, will usually present like that, okay? Obstructive signs, okay? Constipation. The stool frequency or the stool shape will change as well. So that's in the sigmoid. Other than that, since it has a narrow lumen, the pressure in this area of the bowel is the highest, okay? So if you have someone who will increase this pressure based on their lifestyle, poor lifestyle choices, has constipation, this pressure will go even higher, which can be a risk factor for diverticulum formation, okay? For diverticulosis. So we'll get to this later on and repeat this again, inshallah, later, but this is the basics of the anatomy. For blood supply, there's not a lot to discuss. Obviously, the blood supply is going to be the celiac artery, the celiac trunk. Then you have this, which is the superior mesenteric artery, which is supplying the colon until this point over here, the transverse 2/3 of the colon. The rest of it will be supplied by the inferior mesenteric artery. The important anatomy in terms of its blood supply is these two regions, this and this, okay? These two regions, which is the splenic flexure and the rectosigmoid junction, or the sigmoid itself, have the weakest blood supply, okay? This is what we call the watershed areas. So in the case of anyone who has hypovolemia, hemorrhagic shock, does a surgery that's very invasive, or not invasive, but hemodynamically taxing, like for example, a AAA, an abdominal aortic aneurysm repair, where they're going to lose blood supply basically, or you're going to need to clamp a few arteries. These areas of the colon are very susceptible to ischemia, okay? So you will have ischemic colitis in these two areas. These two areas are the most commonly affected areas. That's pretty much all you need to know in terms of the blood supply implications. For imaging, this is imaging of the small bowel. Again, not too important in terms of things you need to identify in this image. This is just for your own orientation to know where the bowels are. This is the duodenum, the first part, second part, third part, fourth part, and this is all the loops of the bowel. This is going to be the ileocecal valve, okay? For the large bowel, again, same thing. To identify that this is a large bowel, it's bigger and it has the haustrations, okay? So you can see this is a haustra right here, this portion right here, okay? This is how you can tell that this is a large bowel. The parts, the cecum, ascending colon, you have the transverse colon, descending, and then the sigmoid, okay? Now, if you have someone who has a GI bleed, okay, and you need to identify where that bleed is, you have certain modalities that you can use, okay? Now, what are these modalities? The first one is an RBC scan, or an RBC scintigraphy. The other one is an angiography, which is you inject a dye into the vessels and you see where you have a point where you have a bleed, which would be a collection of blood, okay? You can apply this further and do something called a CT angiography, which you can visualize the anatomy with the blood supply. So it's the best one to use, a CT angio. In terms of what you need to memorize is this number, okay? How sensitive it is to detect certain bleeds. RBC scan has the highest sensitivity out of all of them. It can detect a bleed at a rate of 0.1, okay, milliliters per minute. Angiography, it can only detect it if it's over 0.5, okay? This is the only significant portion of this entire thing. You need to memorize these two numbers. 0.1 for RBC scan, which makes it more sensitive. Angiography, if it can detect it, if the bleed is more than 0.5 milliliters per minute, okay? We're done basically with the basics of the large and small bowel. We'll go into the diseases now. The first broad symptom that we're going to talk about is diarrhea, okay? Diarrhea is defined as an increase in the stool fluidity and, importantly, the stool frequency for more than 3 times a day. Now, there are many different ways we can classify it. The one that is very, very important is the timing of the diarrhea. Acute is under how many weeks, guys? Okay. Below 14 days or below 2 weeks, okay? 2 weeks is the cutoff. If it's chronic, it's above how many weeks? More than 4 weeks. Good. Now, persistent is 2 to 4 weeks. Not too important to remember persistent and its causes and any of that. Okay, so just focus on acute and chronic. Acute diarrhea is usually because of infectious causes. Okay, that's the most important one. Acute is because of infectious. There are other causes such as toxins, drugs can cause acute diarrhea, but it's not too important for you to remember. Know the infectious causes, which is all of micro. Okay. For chronic, we can differentiate it further into depending on the mechanism of diarrhea. How can it cause diarrhea? Which we'll get to inshallah later on. Okay. So, as I said, we'll go into acute diarrhea first. Acute diarrhea is caused by GI infections. You have many types of infections. The most important thing is someone has diarrhea, especially watery diarrhea. Where is it? Where is the pathology? Is it in the small intestine or the large intestine? If someone has watery diarrhea, you guys tell me. It's usually in the small intestine, okay? So if someone has diarrhea, which is usually in the diarrhea, watery diarrhea, it's usually a pathology of the small intestine, okay? Which causes fluid abnormalities and electrolyte loss, okay? If someone has dysentery, which is bloody diarrhea with mucus, this is usually a pathology of the large intestine. Okay. There could be overlap of both, of course, as majority of these diseases, but it's usually from the small intestine, and dysentery is usually from the large intestine. Okay. It's important for you guys to differentiate the causes of watery diarrhea versus bloody diarrhea in terms of what organism causes what. Okay, and we'll get to this, inshallah. So, enterocolitis is basically inflammation of both the small and large. Gastroenteritis is basically a group of symptoms such as abdominal pain, distension, also nausea, diarrhea, and so on. Okay, so now we get to the infectious causes. Now from here on, I'll show you a picture and you tell me what the organism is. The first one. What organism or what infectious causes this? Good. This is rotavirus. Good. Which is a virus. What type of virus is rotavirus? In terms of the DNA, RNA, what type? Double-stranded RNA, not DNA. It's a double-stranded RNA virus. It's a non-enveloped double-stranded RNA, which allows it to become more protective in the GI. Basically, it doesn't let it get degraded easily, and it doesn't let it degrade by some cleaning stuff. I forgot about that. But anyways, it's non-enveloped. Now, rotavirus, very importantly to remember about this is that the shape, it looks like a wheel. That's number one. Number two is what age group is most commonly affected? Children, good, kids. What type of diarrhea does it cause? Watery or bloody? Watery diarrhea, good. So this causes severe watery diarrhea in children, okay? Now, does this affect developing countries or developed countries more? Do you guys know? Developing, why? Why is it in developing and not developed? Other than hygiene, there's an important thing. Vaccines, okay? They can give vaccines for rotavirus, okay? So these are the two reasons why it's more in developing countries is because of the water hygiene is obviously better in developed countries. And in developed countries, you have the vaccination programs, okay? So you can get vaccinated for rota. Important thing about rotavirus vaccine is there is a contraindication to this, which is intussusception. Okay. If someone has a history of intussusception, you cannot give this vaccine. This is very important to remember. Okay. That's it pretty much for rota. What is this virus? Norovirus, good. What type of virus is this? Good, it's a single-strand RNA. Is it positive or negative strand? Positive, nice, good. So it's a positive sense single-stranded RNA virus, okay? Again, it's non-enveloped. Now, this one does not have a vaccine. It usually affects the elderly, or not elderly, adults, age group. And more commonly, and actually before that, does it cause watery or bloody diarrhea? What type of diarrhea does it cause? Watery diarrhea. Good. Usually in questions, it will give it to you as this. It will give it to you as people are on a cruise ship. Later on, they developed severe watery diarrhea. Okay. That's usually how it's given, okay, in terms of the presentation, okay? Usually a group of people at once with watery diarrhea, okay? So that's all that's important for norovirus. This one, good. This is adenovirus. Adenovirus is what type of virus? Double-stranded DNA, good. The most important thing about adenovirus that I need you guys to remember is this in histology, okay? This is a dense central intranuclear inclusion, okay? Like memorize that term. Dense central nucleated intranuclear inclusion. The way it's differentiated from CMV, okay, because that's like the confusion point, I guess, is that in CMV there's intracytoplasmic inclusion and the whole cell is big, okay? Here it's not, it's just the nuclear inclusion, okay? So that's adenovirus, that's all you need to know. And yeah, how about this? A patient comes to you with diarrhea and shows you this color. Good. This is rice water diarrhea. Now, rice water stool is because of what organism? What's your suspected organism? Vibrio, okay? Vibrio is what type of bacteria? Gram-positive or negative? Negative. What shape? Is it cocci or a rod? Rod, it's usually described as a comma-shaped rod. Good. Is it oxidase positive or negative? Positive, excellent. And now lastly, is what important culture media can you use for Vibrio? TBCS, good. Which is thiosulfate citrate, TCBS, thiosulfate citrate bile salt agar, okay? Which will tell you it's both selective and differential for Vibrio. Now, for Vibrio, there's two common strains that you need to know. It depends on if it's sucrose fermenter or non-fermenter. If it's fermenter, it'll appear yellow, which is what strain? Cholera. If it's black, if it's a non-sucrose fermenter, parahemolyticus. Perfect. Remember these two images, okay? Remember that Vibrio cholera is sucrose fermenter, so it appears as yellow on TCBS. Parahemolyticus will not appear as yellow, okay? Because it's not sucrose fermenter. Now you have a patient who just recently traveled and presented with watery diarrhea, okay? What's a most common bacteria that can cause watery diarrhea? One of the most. And the key term is they just traveled. Perfect. Enterotoxigenic E. coli. Good. If E. coli were to most commonly present in pediatrics, what's the strain? If it's in pediatrics, the children. Same thing, watery diarrhea. EPEC, okay? Enteropathogenic E. coli, okay? Now, if it causes bloody diarrhea, what strain is it? Good. So it's either or. It's enteroinvasive or enterohemorrhagic. Both can cause bloody. However, which one is more associated with hemolytic uremic syndrome? The enterohemorrhagic, EHEC. Good. Now, EHEC, there is the serotype 0157H7. Okay, that's what the stereotype is. Serotype is. Okay. Now, for E. coli, it's a gram-negative. We all know it's a gram-negative rod. It's a lactose fermenter. Is it indole positive or negative? Positive. I remember I said this in renal, and it wasn't mentioned in renal, but it's mentioned now. Okay, Klebsiella is negative. Excellent, good. Now, if it's a lactose fermenter on McConkey agar, will it appear as pink or yellow? Pink, good. Okay, so it's the pink here. This is the E. coli. Now, if you have a child with hemorrhagic diarrhea, bloody diarrhea, dysentery, and you do a culture which is looking for the sorbitol fermentation, will it be negative or positive if someone has bloody diarrhea and has E. coli? Good. It will be sorbitol negative. To clarify this, enterohemorrhagic E. coli, the 10157H7 strain, will be sorbitol negative. This is very important to remember. Sorbitol negative. Okay? That's E. coli basically. Know how these strains cause diarrhea, like the exact mechanisms. For example, Vibrio will increase cyclic AMP. Increased cyclic AMP will cause increased chloride to basically secreted, and this will have water follow with it. For example, enteropathogenic, it will stay on the surface and it causes diarrhea or something. Know the exact mechanisms for this, especially like EHEC, the Shigella-like toxin that it has. Know the mechanism of that. Now, someone has bloody diarrhea and will present with something like this, which is blood and mucus. It looks disgusting. Okay, so this is dysentery. Okay. Now, to look into causes of dysentery immediately, you have this one, which is Shigella. Okay. Now, Shigella, is it a lactose fermenter or a non-fermenter? Non-fermenter, good. Which will be yellow or pink? Yellow, it's this one, okay? So it's a lactose non-fermenter, good. Now, Shigella has the Shiga-like, has the Shiga toxin itself, and it can cause hemolytic uremic syndrome in children, okay, and in adults as well. Now, Shigella has a specific agar that I want you just to memorize what it looks like, which is this one. Do you guys know what it's called? Xylose lysine deoxycholate. Okay, so this is the xylene lysine deoxycholate agar. Okay, again, Shigella is a gram-negative rod non-lactose fermenter. That's how you can differentiate it from EHEC. Okay, in terms of the virulence factors that it has. Okay, tamam. Someone who just recently ate chicken, okay, undercooked chicken, will present with inflammatory diarrhea, okay. This is Salmonella, good. Now, Salmonella, is it lactose fermenter or non-fermenter? Which one is it? Non-fermenter, good, which is yellow, as we mentioned a lot of times already. Now, the most important thing about Salmonella that I need you guys to remember is this picture. What is this agar? The Salmonella Shigella agar, okay? Now, good. Now, Salmonella produces H2S, okay, hydrogen sulfide, which will basically bind with iron, okay, with ferrous, and will form this, the black dots and the black parts over here. Shigella does not produce H2S, hydrogen sulfide, so it won't appear as this color, okay? This is very important to remember. Now you have a patient who went camping and then presented with inflammatory diarrhea, started off as watery, then became bloody, I think is how the sequence goes. You asked them about what they ate. They ate poultry and when they went camping. Good. Okay. Now it's Campylobacter. Also in the question stem, they might give you this, is that 3 weeks later, they tell you that, oh, suddenly they have loss of sensation that's started with the foot and now reached the knee, for example, which is Guillain-Barré syndrome, okay? Ascending paralysis. Rocky Mountain spotted fever, as someone mentioned in chat, will present with the skin manifestation. That's very important, okay? The skin manifestations is very, very key for Rocky Mountain spotted fever by rickettsia, okay? Now, for Campylobacter, it's a gram-negative as well. It's a rod. It's oxidase positive. Important is that what temperature can you grow Campylobacter? This is like the key number. It's 42, okay? It's the only time. No, it's not. It's not. Campylobacter is not from Rocky Mountain. Completely two separate entities. Someone mentioned in chat, so I just clarified it. It's not the same. Okay. Campylobacter is grown at 42 degrees Celsius. Memorize this, okay? Exactly, it's thermophilic. Now there's two agars here. Do you guys know what this one is? Campy blood, and this one, it's black, so it has not iron. Charcoal, good. So it's called Campylobacter charcoal differential agar, okay? Uh, memorize these two. If you see this black agar and someone who has GBS, pick this, okay? So that's how you could get this in OSPE, okay? We're done with bacterial causes. Now we go into parasitic. This is a key image, probably ingrained in everyone's heads. Giardia, okay? What form of Giardia is this? Is it cyst or trophozoite? Cyst, good. How about this one? Trophozoite, okay? Now, Giardia, commonly how it presents is that someone also traveled, drank from a unclean watery source, and then presented with watery diarrhea. The key thing about the watery diarrhea is it's very specific. There's a specific characteristic of it. Other than that can cause chronic diarrhea, that is very true, is that it's very smelly. Exactly. It's basically, it's the same as steatorrhea, okay? Because this one will cause malabsorption, okay? And with malabsorption, specifically fat malabsorption, you'll have stool that's mixed with fat, okay? That's what steatorrhea is, which is very, very bulky and smelly, okay? So that's a key difference in terms of the diarrhea that Giardia causes, okay? That's pretty much it. You ingest the cysts in the water, then it forms into the trophozoites, and so on. Exactly. The infective is the cyst, diagnostic is the trophozoite, and then the lifestyle is direct. Thank you. Okay. Uh, okay. How about this patient? What do they have? Good. Entamoeba. Okay. So this patient has entamoebiasis. What type of diarrhea does it cause? Watery or bloody? Bloody dysentery. Okay, good. What form of entamoeba is this? Cystic. Good. What's inside the cyst? RBCs. Good. Okay, these are RBCs. This is the nuclei. Okay. Now, sorry, this is the trophozoite. This is the cyst. Okay. This is the cyst, which has the nuclei. Okay. The nuclei, the number is important because I don't have this directly memorized, but it's in your slides, and Dr. Mohammed loves to emphasize on this. If it's four, it's Entamoeba histolytica. If it's more than four, it's Entamoeba coli, I believe. And then if it's eight, it's Entamoeba dyspecine or something. Look into the slides for this, but the most important thing is Entamoeba histolytica will form the diarrhea, the bloody diarrhea. It's more clinically important, and it can form abscesses, okay, as well. That's the most important thing about them. Now you have this patient. What do they have just by the image? Okay, good. This is Cryptosporidia. Okay. So Cryptosporidia, what demographic of patients will present with Cryptosporidia usually? What, okay. More importantly, is they have a chronic disease. Not demographic, like AIDS patients, okay? AIDS, HIV, immunocompromised patients are susceptible to Cryptosporidium because it's opportunistic, okay? So Cryptosporidium is one of the opportunistic AIDS infections that can present with patients with AIDS. Most important thing is Cryptosporidium is that it's acid fast positive. Okay, so it's similar to TB in terms of the staining here. It's the same stain, acid fast. Okay. This is the most important thing to remember about Cryptosporidia. Usually in the question, it will give it to you as an AIDS patient with HIV, present with watery diarrhea. You do stool investigations. It's acid fast positive. What's the organism? Cryptosporidia. Okay. How about this patient? Strongyloides. Okay. So this is Strongyloides, stercoralis. Okay. Yeah, so Strongyloides stercoralis is a thread worm. It acts similarly to a hookworm in terms of it will go through the skin of the feet and will go on into the bloodstream, then go to the GI. Another thing that's very important about this threadworm is it causes autoinfection. Okay, so it lays its eggs, the eggs will hatch and it will repeat again. Where would it hatch? In the intestines itself. Okay, so it will cause autoinfection. This is very important about them. The important infective form of Strongyloides is the filariform larva. Okay, that's also very important about this. Now, what do we call this sign over here in the skin? Larva occurrence, good. There's three types of manifestations of strongyloides. There's acute, chronic, and disseminated. This is both in acute and chronic strongyloids, okay? That's pretty much it for that. Now you have this patient. This patient was hospitalized, and then you gave them antibiotics, you gave them clindamycin. A week later, they came to you with diarrhea. That started off watery, then became inflammatory. Pseudomembranous colitis. Good. What's the bacterial agent that caused it? C. diff. Good. So this is a C. diff infection. The way I described it in terms of the clinical scenario is key. Okay. Usually a hospitalized patient. Okay. Usually a patient who has been given antibiotics, specifically clindamycin, and presented with diarrhea later on, usually because of C. diff. Okay. C. diff infection. Now, C. diff has two different toxins, toxin A, toxin B. There is multiple genes related, and you guys need to know the genes very well. So the toxin A, B, D, C, and E. Okay, there's five of them. There is one of them that's more specific. Okay, that's very important in terms of if it's more severe strain, which I think it's toxin C. Toxin C will suppress toxin A and B, which is what causes the diarrhea. If toxin C is mutated, this will cause toxin A and B to go up. Okay. Just clarify that from your slide. There's one slide from Dr. Mohammed that explains this. Okay. But anyways, you have two toxins, toxin A and B. Toxin A will cause the watery diarrhea. The toxin B is the cytotoxic toxin. Okay. This is what causes a pseudomembranous colitis, which is what this patient has. Then later on with pseudomembranous colitis, you can have this one, which is toxic megacolon, okay, as the later stage of it, more severe. Now, for these patients with C. diff, how can you manage it? What drug can you give? Okay, you give fluids, good. So there's typically two agents that you can give. You can give fidaxomicin or vancomycin. The way you give it is important. You give it orally. Okay, you cannot give it IV. Why? Because these antibiotics have a very poor oral bioavailability, which is what you need. Okay, you want this drug to stay in the intestines. Okay, to stay in the bowel to fight off against the C. diff. So you give it orally. Okay, there's no role for IV medications in this case. Okay, now what is this? Again, it's C. diff, but what are these agars? What is this one? This is CCFA. Okay, this one is CCFA. It's like sporine something. Okay, and then this one is the C. diff agar. Okay, exactly, CA agar, which is the C. diff agar. Okay. These aren't too important to remember. The ones you need to remember how it looks like is the Vibrio, okay, the TCBS agar, the Shigella, and the Salmonella. These three are very important to memorize how they look like, their agars, okay? For C. diff, you don't usually culture them on any agars. The best diagnostic tool for you is to check for the stool antigens, okay? This is the most important, to check for the toxins. This is the best way to diagnose it, okay? And the way that it's usually diagnosed. You can agar them, but it's not usually done, okay? Now again, this is also C. diff. It's a gram-positive rod, and it's a spore form, okay? This is a terminal spore that you can see on image, okay? This is just, you might get this image and they ask you what this is. It's C. diff, okay? It's a gram-positive rod, okay? All the Clostridia species are gram-positive rods, okay? Now, this is just very quickly, is there's two other bacterial agents that I want you guys to know that causes gastroenteritis, that causes diarrhea. Usually, if someone was at a food gathering, at a picnic, and later on developed diarrhea within 6 hours, the pathogen is Staph aureus. Okay, usually, most commonly. Staph aureus is usually when you eat, for example, leftover food salads. And the keyword that I always look at, like myself, whenever I'm trying to answer and I know this is Staph aureus, is mayonnaise. I don't know why. It's always associated with mayonnaise. Okay. So that's Staph aureus. Why does Staph aureus cause it very acutely within 6 hours? Is because it's preformed toxins. Okay. It's already formed. It has these toxins, so it damages the GI immediately. Okay, which is the enterotoxin. The other one that I want to remember is Bacillus cereus. What food is associated with Bacillus cereus infection? Rice. Good. Memorize rice. You see rice in the question, it's associated with Bacillus cereus. Okay? That's pretty much it. This is a summary that I put from first aid that summarizes majority of them, but we've already been through almost all of them. Okay? So then we're done with acute diarrhea. Now we go into, well, what lecture? This is from Dr. Sahibani's acute diarrhea lecture. Okay. He put a question on rice, like patient ate rice, later on had diarrhea. It's Bacillus cereus, so memorize that. Okay. Anyways, now chronic diarrhea. You can use this for acute as well, but as I said, acute is usually infectious, so you don't really look at any other things. For chronic diarrhea, we can classify this further into what type of diarrhea does it cause. The two most important one is osmotic and secretory diarrhea, okay? So osmotic diarrhea is when you have, if you look into the bowel, okay, of this intestines, if there's anything here that's hyperosmolar, that's allowing water to go into the lumen, okay? That's typically what osmotic diarrhea is, okay? Something here that's pulling water from the walls into the lumen that's causing the diarrhea. That's osmotic. So these are solutes that are not absorbed. So by that, the causes of osmotic diarrhea is usually malabsorption, okay? Patient who has celiac disease, patient who has lactase deficiency, lactose insufficiency, uh, they can't, for example, digest or absorb carbohydrates. They can't break down carbohydrates. It will accumulate in the bowel lumen. So this will absorb or bring water into the lumen. Okay, so that's part of the causes. Other than that, you can give, for example, agents such as magnesium, which we'll get to, that are anti-constipation or or laxative drugs. So, for example, magnesium, lactulose, which are osmotic agents. So it will again push the or bring in the water into the lumen. Okay. So these are the important causes of osmotic. Other than that, you have, for example, diabetic, which can be both osmotic and secretory. The mechanism isn't completely clear and it's not required from you guys to know. Okay. Anyways, uh, that's pretty much for osmotic. For secretory, it's something in the bowel wall that's allowing or that's causing secretions to occur. There's increased secretions. The most important cause of secretory is anything that causes an increase in the vasoactive inhibitory intestinal peptide, which is VIP. So, for example, patients with VIPoma, which is a tumor that's secreting VIP, this will cause an increase in the water that's being secreted into the lumen, okay? There are infectious also causes of this. For example, cholera, exactly. For example, increases cyclic AMP, which will push chloride into the lumen, which will allow water to flow with it, okay? This is the most important cause of it, okay, for secretory. Exudative, which is also called inflammatory chronic diarrhea, is caused by inflammatory bowel disease, okay? These are the two types. Because you have damage to the intestinal wall, and the damage to the intestinal wall is usually very severe, okay? It will cause either bloody or watery diarrhea, depending on the location. This causes a disruption in the ability of the bowel to absorb fluids, absorb anything. So this will allow it to go as diarrhea. Okay, this is the exudative, which will basically be mixed with blood or mucus. Okay, and this is an IBD. The last thing is motility disorders. Other than that, you have fatty, but fatty is self-explanatory. But motility disorders is anything that causes an increase in the activity of the bowel. Okay. So in this case, it's IBS, okay, which is a mixture. You have patients who sometimes present with diarrhea, sometimes present with constipation. Okay. Then you have diabetic neuropathy, which will affect both. It causes secretions and it causes a motility change, okay, in diabetes. Other than that, you have, for example, hyperthyroidism can cause increased motility of the bowel, which will cause diarrhea as well. For fatty diarrhea, it's usually due to pancreatic insufficiency, where you have more fat in the stool, and the more fat in the stool will draw fluids in and will cause fatty diarrhea, which is called steatorrhea. Okay. That's pretty much the classification of diarrhea. The most important two that you need to know are these two and the different causes of them. Okay. osmotic and secretory, because that's the majority of them. Also within this is you need to know the osmolar gap, okay? The osmolar gap will tell you is in this, is there a unmeasured osmoles, or is it just that the patient is having diarrhea that's just watery because of secretions, okay, secretory diarrhea. Basically, osmolar gap will tell you if it's hyperosmolar or if it's just secretory, okay? Hyperosmolar is if there's something that's causing the diarrhea, if there's something in the lumen that's allowing the fluids to go into the lumen, okay? That's basically osmolar diarrhea, as I mentioned. So by that is that the majority of the osmoles will be unmeasured because it's not going to be from these regular ones that we always have in the stool. While in secretory, you're not going to have unmeasured osmoles, okay? You're not, because that's the secretory diarrhea. The cause of it is an increase in VIP that causes chloride, for example, to be secreted, okay? So it's not going to be unmeasured osmoles. The magic number that you need to know are these two, 50 and 125. Below 50 is secretory. That means that there's no unmeasured osmoles. Above 125 is osmotic. There's a lot of unmeasured osmoles that's causing the diarrhea. Okay? Memorize this image because it came for us last year. Okay? And it was kind of a shock to a lot of us that this image came. Okay? Is diarrhea clear to you guys? Or do you want me to repeat anything? Good. Now, for the management of diarrhea, it's kind of important to remember a couple of things. I did not put any pharma concepts here because there's barely anything, and I'll just mention it now. Is the first thing and the most important thing in diarrhea is fluids. Okay, you need to give fluids. That's the most important thing. Okay, oral rehydration solution. Okay, good. Now, I will mention that I'll ask you guys actually, if someone has having bloody diarrhea, can you give anti-motility agents, antidiarrheal agents? Yes or no? If someone's having bloody diarrhea, can you give antidiarrheal agents? No. Good. Why? Is because you want the diarrhea to happen to wash out the organisms that's causing it. Okay. For usually in patients who have acute diarrhea, you don't give agents. Okay. You kind of just wait it out. You give fluids and that's it. Okay. For some of the bacterial causes, you can give certain agents. So, for example, Giardia, you can give metronidazole. Uh, okay, and basically specifically treat the organism that's causing it. However, it's not always it's given. Okay. Bloody diarrhea, as I said, you usually never give antidiarrheal agents. Okay. Chronic, you treat the underlying cause. What's causing this chronic diarrhea? You try to treat it. Okay. That's basically the treatment of diarrhea. For the agents that you can use antidiarrheal is the most important one is an opioid receptor agonist. What is that drug called? This is the most important drug I want you to remember. What is that drug called? Opioid receptor agonist. Other than codeine. Codeine can, but no. Does not cross the blood-brain barrier. Loperamide. Good. Loperamide. This is the drug I want you to remember. Loperamide. Okay. It's an opioid that does not cross the blood-brain barrier, so it has no potential to cause addiction and dependency and so on. At the same time, it has less of the analgesic effect. Okay, loperamide. Memorize that drug out of all the drugs. This is they love to question this. Dr. Santosh, Dr. Dilip love to add this in the exam. Okay, that's pretty much it for diarrhea. We'll go to the we'll go to the next thing, which is constipation. Okay. So constipation is the direct opposite of diarrhea. There is a diagnostic criteria for this, which is the Rome 4 criteria, which has, for example, straining, lumpy or very hard stools, sensation of incomplete evacuations, and so on. There's no IBS, okay? And it's rarely present without the loose stools, normal stools is rarely present with the use of laxatives. Now, the important thing about constipation is you need to know what are the causes of constipation. So constipation, we can classify it to two types. There's primary and there's secondary constipation. Primary constipation is when all the other causes of secondary constipation, which we'll get to, is ruled out, okay? Usually, primary constipation or functional constipation is in a patient who has poor lifestyle habits, okay, is obese, the diet is horrible, not enough fibers, not enough fluid intake, and so on. So the management of this is fairly simple, is you reverse all of that. Okay, you tell them, okay, you need to lose weight, have a better diet, increase fiber diet, increase hydration, and it usually will clear up. Okay. The secondary cause of constipation is due to an underlying disease. Okay. So usually, for example, underlying diseases could be hypocalcemia, could be hypothyroidism, could be someone who's taking opioids and anti-diarrheal agents, for example, could be the cause of constipation, could be a patient with, what else, for example, it can cause constipation, could be due to an obstructive cause and an anatomical cause. There's many, many causes, okay? Could be, for example, the bowel outlet, okay, itself, the anal outlet could be obstructed in that case. IBS as well, but usually when you're diagnosing functional constipation, you exclude this, okay? But yes, IBS can cause constipation, of course, as well. And yeah, like these are the causes of constipation. You need to be able to exclude those, and then you diagnose it with functional constipation. Simply enough, if you have someone who's diagnosed with secondary constipation due to any of these causes, you treat the underlying cause, okay? So that's pretty much constipation in a nutshell. Now, one way you could diagnose constipation is using a colonic transit study. Basically, you give this patient rings, around 24 rings, and you tell the patient to swallow them, and you follow them up 5 days later. There is a cutoff number of what's it called, rings that are present in the bowel remaining to tell you that this is constipation. The cutoff number or the percentage is 20%. If there's greater than 20% of the rings are still present, this is diagnostic for constipation. Okay. And this is at day 5. Okay. Is this clear? If there's more than 20% of rings present at day 5, this is diagnostic of constipation. Okay. For the two causes, you have this, which has hypomotility or colonic inertia due to any number of causes, such as hypocalcemia, hypothyroidism, and so on. It's because of the motility of the bowel is slow, okay? So the rings will be all over the place. However, if someone has a functional outlet obstruction at the anal canal, for example, due to Hirschsprung's, for example, if it's a child, okay, or anal stricture, for example, or even someone who has anal fissure, hemorrhoid that's very painful for them to pass stool, they will have this, okay, which all the rings are gathered at the rectosigmoid junction, okay, at the rectum. Tamam. In terms of management, it's fairly straightforward. It's firstly try to treat the underlying cause and lifestyle modifications for patients with primary constipation or functional constipation. Treat the underlying cause of the secondary constipation causes. Now, there are many, many, many drugs you can give. There's a bulk-forming laxative such as cellulose, and psyllium. These will draw what's it called, fluid into the gut lumen. Then you have osmotic, which we've gone over. Magnesium is a cause, and we already mentioned magnesium in the peptic ulcer disease drugs. It causes diarrhea. Okay, so that's why in the peptic ulcer you give it with aluminum, which causes constipation. Another important thing about the osmotic laxative is the function of, or the mechanism of lactulose. Lactulose can be given in two scenarios. Someone with constipation and someone with what else? What's important application of lactulose? Someone with liver disease, which is hepatic encephalopathy. Perfect, good. The mechanism of this in hepatic encephalopathy, I'll mention it, inshallah, in the liver session later on, okay? Then you have stimulant laxatives, which will basically stimulate the bowel to move, okay? And, the peristalsis to occur, which is by senna and bisacidil. Then emollients, which is basically are stool softeners, which will make the stool softer, okay? That's pretty much it. For the what's it called? For the adverse effects and the side effects, it's usually all diarrhea and bloating. Important is senna. Senna causes something called melanosis coli, which are these black spots that you'll see in the colon, okay? Melanosis coli, okay? That's pretty much it for constipation. Is everything good till now? Any questions? The color could be darker, I believe, with senna as well. But yeah, that's about it. Okay. Okay, tamam. Now we'll go to the most important pathology of the bowel, which is IBD. Okay. Now IBD, uh, there's two that you guys need to perfect. Okay, you guys need to know everything about these two: Crohn's and ulcerative colitis. I will quiz you guys and ask you guys about the difference about the between the two, and then we'll go into images. Okay. Now, which one from the two? You can just say in the chat CD or UC, okay, to speed things up. Which of the two will most likely present in the rectum? Always, 100% will present in the rectum. UC, ulcerative colitis, good. Which one will present usually most commonly in the terminal ileum? Crohn's disease, good. Which one is typically the extent of this disease is it's continuous. So it starts at one place and moves up. Ulcerative colitis, good. Which one is characterized as skip lesions? Crohn's disease. Which one can happen all over the GI tract, from the esophagus all the way down? Crohn's disease, good. Which one will present as transmural inflammation of the wall? Crohn's disease. Which one will present as mucosa and submucosal inflammation only? Ulcerative colitis, good. Oh, good. Which one will most likely present as watery diarrhea? Sometimes bloody, sometimes, but usually watery. Crohn's disease, good. Which one present with bloody diarrhea? Ulcerative colitis, perfect. Tamam. Which one will present as strictures as a complication? Crohn's disease, good. Which one presents with fistula as a complication? Crohn's disease, good. Which one can present as toxic megacolon as a complication? UC, excellent. Which one will have in histology non-caseating granulomas? Crohn's disease. Which one will have cobblestone mucosa? Crohn's disease. Which one will have pseudopolyps? UC, excellent. Okay, these are the important causes. Other than that, are the important differences. Other than that, which one is smoking a protective? UC, good. Smoking is a cause for Crohn's. Okay, good. Tamam. So these are it, okay? We've gone through a lot of them. To mention the ones that we haven't, the bowel wall will be thicker in Crohn's, thin in UC, and we'll see a very characteristic sign on imaging for ulcerative. Transmural inflammation limited to mucosa. Pseudopolyps will be higher in UC. Ulcers will be more superficial because, again, it only involves the submucosa and the mucosa. All this we mentioned already. Perianal fistula, as we already mentioned, fistulas are more important in Crohn's disease. There is fat and vitamin malabsorption in Crohn's. Why? Why will it have fat and vitamin malabsorption? Terminal ileum, perfect. Now, I'll get to this later, inshallah. Now, malignant potential. Is it higher in UC or in Crohn's? UC. Why? Is because of the extent of the colonic involvement. Ulcerative colitis will always involve the rectum and it will move ascend upwards. Okay. So with the extent of the colonic involvement, there will be a higher risk of cancer. Okay. Now, surgery is curative for Crohn's or for ulcerative? Ulcerative colitis. Surgery, and we'll get to when to do surgeries for Crohn's, is not curative. Why? Is because it can happen anywhere in the GI tract. So it can happen again. It can recur after surgery. Okay, and we mentioned the rest of this. As I said, the most common area for ulcerative colitis is the rectum, which is what we call proctitis. Proctitis means inflammation of the rectum. Okay, if it extends, it's proctosigmoiditis. If it extends and it's left-sided or extensive colitis, if it involves the entire colon, this is what we call pancolitis. Okay. Crohn's is usually in the ileum. Okay, but it can be everywhere. Okay. So that's pretty much that. Now we'll go into the diagnosis. Now, for these patients, if you do imaging, which disease is this? Which IBD is this? Crohn's disease. Excellent. Good. What do we call this sign? If you guys know. Okay. This is what we call, this is Crohn's disease. This is what we call a string sign. Okay. Number one, this is going to be in the terminal ileum. That's number one. Number two is because the inflammation is transmural, it will cause thickened walls, which will cause the lumen to be very thin. So this is what we call a string sign. Okay, because of the thin lumen. So this is a Crohn's disease patient. Here you have just inflammation. It's not really too clear, and this image is not really high yield for you guys to know. This image is high yield, the string sign. This one is just, there's inflammation happening in the walls, it's transmural, and then you have deep ulcerations that's happening in the walls. Not too important to remember this image, okay? How about this patient? Do they have ulcerative or Crohn's disease? This is also Crohn's. Why can I say it's Crohn's? The wall extent. It's transmural, exactly. Okay. So this is involved the entire wall. Look at the normal wall of the bowel over here. Okay. It's thin. Here you have a very thickened wall. It's involving the entire wall. As well as that, there's this in the mesentery. This is what we call a comb sign, like a comb, because it's involving the mesentery as well. Okay. So this is why I can say that this is Crohn's. This is what we say is a target sign, and there's no narrow lumen, exactly. This is what we call a target sign, not specific for Crohn's, like the name target sign. However, it's just showing you that there's narrow lumen, okay, and there's a thickened wall, okay, which is transmural inflammation, okay? This is Crohn's disease. Crohn's sign is this one, this on the mesentery, okay? Tamam. What does this patient have? Crohn's or ulcerative? Firstly, tell me. Crohn's disease, good. So this is a fistula. This is something called an enterovesical fistula, which is between the bowel, enteral, vesicle means bladder, okay? So usually they might present with chronic UTI, okay? So dysuria, pyuria, if you do investigations as well, suprapubic pain, so on, okay? This is one complication of Crohn's disease, okay? Now, for you guys just to know, like not too important, is that Crohn's disease can be classified into multiple types. There's like the obstructive, fistulizing Crohn's, and so on. This is where they might only present with a stricture, so they have obstruction, and they might only present with a fistula with the Crohn's disease. So that's why we say it's a fistulizing Crohn's. This is beyond the scope of what you guys need to know. Okay, but anyways, fistula can happen with Crohn's. And you can have perianal fistula as well, and we'll get to that inshallah in the anorectal part. Now, guys, tell me, all these four can be seen with what? Crohn's or UC? When you do gross Crohn's disease, excellent. What is this? What is this image is showing you? The first one. Cobblestone mucosa, good. Second one. The second one, aphthous ulcer, very good, is in the mouth. Okay. So aphthous ulcer will be in the mouth. Okay. These are linear ulcers. Good. This is the linear ulcer. Okay, tamam. The red parts over here. Okay. These are linear ulcers. Aphthous ulcer, again, Crohn's can present with aphthous ulcers in the mouth and the lips. Okay, because why? Because it can affect the entire GI. Okay. So it can present with aphthous ulcers. Good. How about this one? This image. Stricture, good, which can cause GI obstruction. How about this one? Fat, or we can say creeping fat. Good. Tamam. Now, what's the most now is this Crohn's or ulcerative? Crohn's. Tell me two reasons why this is Crohn's. Firstly, in this image, and then what's this? Okay, that's number one, non-caseating granuloma. And can you tell me one other reason? Transmural, exactly. Okay, so this is a Crohn's disease. The most important picture is this one. Okay, this image, which shows you this giant cells, which is granuloma. Okay, this is one giant cell over here, and this is another one. Okay, and this is just showing you that the inflammation you have basically clumped up inflammatory cells over here, another one over here, and so on, all throughout the wall of the GI. Okay, that's what this is showing you. Now, what does this patient have? Good. This is ulcerative colitis. What is this sign called? Lead pipe appearance. Good. All right, that's it. This is important. This is so high yield. Okay. You'll get this in OSPE, one way or another. Okay. Either they'll give you a case of a patient with recurrent bloody diarrhea, diagnosed with UC. Which one is characteristic of UC? It's this one. Okay. You will get this. Oh. Now, a known case of ulcerative colitis presents with abdominal distension, hemodynamic instability, bloody diarrhea. What do they have? Toxic megacolon. Good. So megacolon just means that the bowel is big. Okay. Big. Okay. That's it. Toxic just means that there's an extensive damage to the bowel itself. Okay. Usually these patients, you need to treat them with fluids, with antibiotics. Sometimes will require resection, okay, which will lead to a lot more complications later on. Tamam. For megacolon, you have multiple different causes of megacolon, and we'll get to that later. But the most important two causes that I want you to remember is toxic megacolon from UC and toxic megacolon from pseudomembranous colitis from C. diff. Okay, these are the two most important ones you need to know. Is this Crohn's or UC? If you do a colonoscopy and you see this. Ulcerative colitis. What is this? What can you see on this image? Pseudopolyps. Excellent. Good. Is this UC or Crohn's? UC. Good. It's not too important to remember this image, in my opinion. However, just the sake of in case it comes, is there's two things you can identify here. Firstly, is if they give you a more larger image, is it's only going to be in the mucosa and submucosa. That's number one. Number two is you have abscess formation. Okay, crypt abscesses. That's basically all you need to, and the crypts are distorted itself. Good. That's basically all you need to know for this image for UC. Okay. Now, both Crohn's and ulcerative colitis, IBD in general, will have systemic manifestations. You have so many systemic manifestations. Affects the eyes, causes uveitis, episcleritis, and so on, causes arthritis, okay? Can cause pleuritis, can cause many different things, okay? Anemia, and so on. Importantly, is these manifestations are more common in Crohn's. Okay, they're more commonly seen in Crohn's, however, can be in both. Okay, it's not always has to be if they have systemic manifestations, Crohn's, and then if they don't, it's UC. No, it can happen in both. Ulcerative colitis is more associated with the arthritis systemic manifestations. It's more associated with it. Crohn's disease is more associated with the eye manifestations, which is the episcleritis, uveitis, and the skin manifestations. Okay. Now, in ulcerative colitis, there is one extraintestinal manifestation that is very important, which is in the biliary tree. Do you guys know what that manifestation is? Excellent. PSC, primary sclerosing cholangitis. When we get to the, inshallah, the biliary disorders after Eid, I'll talk about this in more detail. But the most important thing about the primary sclerosing cholangitis is its risk with colon cancer with patients with ulcerative colitis. The presence of UC with primary sclerosing cholangitis or presence of primary sclerosing cholangitis in patients with UC is associated with a higher risk of cancer. Okay, so that's why with patients with diagnose UC and you see, okay, this patient also has primary sclerosing cholangitis, you need to do colonoscopy at that point. Okay, you start there. Okay, that's the important implication of that. Okay, other than that, which brings me is there are some genetic what's it called, components in IBD. Do you guys know what gene is implicated in ulcerative colitis? In ulcerative. Well, good, that's in Crohn's. Okay, ANCA. Okay, P-ANCA. Okay, similar to the vasculitis that we had before, P-ANCA. Okay, why is this important? Is primary sclerosing cholangitis is associated with P-ANCA. Okay, so that's one way to remember that. For Crohn's, you have two, sorry, not, I said gene, but antibody I meant, okay? But for gene, for Crohn's, is NOD2 gene, okay? NOD2, okay? For a antibody in Crohn's is something called ASCA, okay? It's a very long name. It's anti-Saccharomyces cerevisiae antibodies, ASCA positive, okay? Not too important. Just remember P-ANCA for ulcerative colitis, okay? Now, in a patient with extraintestinal manifestation in IBD, which one is this? What is the skin manifestation called? Erythema nodosum. Excellent, good. How about this one? Pyoderma gangrenosum. Excellent. That's it. Okay, they will present in IBD. This one, erythema nodosum, is associated with the disease activity of Crohn's. Okay, that's like the only thing to remember about it is if there's increase, or not Crohn's, in IBD generally, if there's increased activity of IBD, this will be worse. Okay, this is associated with it. This doesn't have anything to do with it. Okay. Now, for ulcerative colitis, I did not want to put this, but I remember that one of the batches got this. There is a severity score to ulcerative colitis to see how severe the UC symptoms are, which is what we call the true love and wit severity index. Okay, so it differentiates it between mild, severe, and fulminant. Fulminant means it's very severe, it's toxic. Okay, usually would require surgery or very severe management, so resection or something. Okay. The most important thing about this is just know that this severity index exists. Okay, it's called the True Love and Wit Severity Index. There's five things about them, or six, sorry. Stools, a number per day. If there's more, it's worse. Blood. Uh. Oh wow. Okay. So yeah. Okay. So list these six. Just memorize this table. Not gonna lie. I don't think you need to differentiate the like if it's mild or severe or fulminant, okay? But just know the six parameters used, okay? Which is stool number per day. If there's more, it's worse. Blood and stool. If it's always bloody diarrhea, it's worse. Temperature. If they're febrile, it's worse. Pulse. If it's high, it's worse. Hemoglobin. If it's very low, requiring transfusion, it's worse. And then the ESR, if it's high ESR, which is an inflammatory marker, it's worse. Now, actually brings me to another point, is the inflammatory marker. There's one other inflammatory marker that you have that you can see in the stool. Do you guys know what it is? So there's three inflammatory markers that you have generally. ESR, CRP, which is in the blood, okay, from the liver. And there's one more that you can see in the stool, it's just called stool calprotectin, okay, or fecal calprotectin, okay? Fecal calprotectin, there is a number that you need to remember, which is 50, 50. If it's below 50, it's normal, okay? It means that there's no inflammation that's happening. If it's above 50, it means that there's active inflammation present in the GI. Does it specify that it's IBD? No, it's not specific for IBD. However, it is used to monitor IBD. Okay? So this is fecal calprotectin. All right? Just know that number, 50. Okay? Dr. Fahad Sahibani loves that marker. Tamam. Now, for the management of IBD, you don't need to go into specifics of this. However, just know is that usually when we're inducing therapy for IBD and when we're keeping them on maintenance therapy, we usually use 5-aminosalicylic acid. 5-aminosalicylic acid, the name of this drug is called mesalamine, okay? Or, yeah, mesalamine. The drug name, the actual pharmaceutical name is called Pentazol. You don't need to know that. And usually, when we're inducing therapy in IBD, we use steroids, okay? The goal or the management of IBD is we're gonna try to not use steroids as much because steroids associated with many, many, many complications and side effects. So what we do is we start them on steroids to induce, and we give them also azathioprine, okay, which is immunomodulators. Slowly, we're gonna decrease the dose of steroids, and the key term here is slowly. We slowly taper it. We don't abruptly stop. We slowly taper steroids and we increase azathioprine while we're still giving 5-aminosalicylic acid. This is the only thing you need to know for therapy for IBD. The rest you have other agents. I guess just memorize the name, okay, of it. So for example, anti-TNFs, you have infliximab, anti-integrin, you have natalizumab, and anti-interleukin 12, you can have this one, okay? But anyways, not too important. Just know the names of it. It can be used. When do you use it? Not too important. If they become more severe, you start giving these other drugs, okay, with the drugs that I mentioned. Surgery in UC is curative, okay? You do a proctectomy, which is remove the rectum, is usually curative. You can do something called a proctocolectomy, which you remove the entire colon and you remove the entire rectum as well, and it's curative. The patient won't have IBD anymore, okay? In Crohn's, as we mentioned before, this doesn't work, okay? You usually try to avoid surgeries in Crohn's because you might, if you remove every time this patient has a manifestation of Crohn's, has bowel inflammation, you remove that section, they will eventually end up with small bowel syndrome, okay? Or short bowel syndrome, sorry, short bowel syndrome. You'll have nutritional deficiencies and so on. So you try to avoid this, okay? You only do surgeries if there's complications of Crohn's. So for example, if they have strictures, if they have fistulas and so on, you do surgery to fix that only, okay? And with that, we are done with IBD. Do you guys want me to go back on anything, or is everything clear? For the IBD management, this was in your the review session that Dr. Dilip and Santosh did for you guys. There's no actual lecture for this. They just mention it then and expect you to know it. So anyways, now we move on to the second most important pathologies of the GI, which is polyps and cancers, okay? Now, polyps, we can classify it in multiple different ways, whether it's neoplastic or non-neoplastic in terms of its potential. Another way is morphologically, which is more important. Morphologically, we have two different ways. We have sessile versus pedunculated. What type of polyp is this? Is it sessile or pedunculated? Sessile, good. What does sessile mean? There's no stalk. And I mentioned, and this is a correction for the last session. Thank you, Rushdan, by the way. I mixed them up last time. It's the opposite. Sessile does not have a stalk. It's flat. Pedunculated has a stalk. Okay? So that's the key difference. This one is pedunculated. Why? Because it has a stalk. Okay? These are the two ways you can differentiate the polyps based on the structure. Now we go into which one is neoplastic, which one is non-neoplastic, and key important information about this. I'll explain first, then we identify and we go into detail with them, okay? So first off, which one is the most common type of polyp? Most common type of polyp. What type of polyp is it? Hyperplastic, good. Hyperplastic polyps are the most common type of polyp, okay? Usually it's an elderly patient, and you find it incidentally in colonoscopy, and it's usually in the rectosigmoid region, okay? The most important thing to know about the hyperplastic polyp is its structure, its morphology, okay? It will appear as a serrated polyp. What does serrated mean? A serrated means it's like a sawtooth. Or if you look at a knife and you see the border of the knife, it's like this. Another way is cauliflower. That's pretty good, actually. Okay, so that's hyperplastic polyp, okay? We'll get to the image later. The other type that is very important is hamartomatous polyp. Hamartomatous polyp are generally non-neoplastic, except if it's associated with a syndrome. And if it's in a syndrome, then you start thinking, okay, there might be cancer somewhere else, okay? That's when it gets more important, okay? Now, hamartomatous, we've gone through this in many blocks already, okay? It's just normal tissue with distorted architecture in a normal area, okay? So it's usually in the bowel. In this case here, in the intestine, it's going to be a mixture of smooth muscle with glands, okay? That's not really organized, okay? That's the hamartomatous polyps. There's two important syndromes associated with it. Is number one, Peutz-Jeghers syndrome. Number two is juvenile polyposis syndrome, okay? Now, hamartomatous polyps, I believe, are mostly pedunculated, I believe. Hyperplastic is sessile, okay? I believe. If I'm wrong, please correct me in that piece of information. But then we'll go into the differences between Peutz-Jeghers and in juvenile polyposis syndrome. Peutz-Jeghers is far more important for you to remember. Is number one, it's associated with the LKB1 and the STK11 genes. Memorize this, and that's it. Importantly, it will be associated with the hamartomatous polyps plus mucocutaneous pigmentation. The key image that should be ingrained is usually it's a picture of a guy's mouth, and there's a lot of spots at their lips. Okay, this plus the hamartomatous polyps, Peutz-Jeghers syndrome. Okay, this one is an autosomal dominant syndrome. And usually the hamartomatous polyps will develop where in the bowel? What is the most common location for Peutz-Jeghers polyps in the entire bowel? Small intestine, good. So it's usually in the small bowel. Tamam. That's what you need to remember for this. There is an increased risk of thyroid, breast, lung, pancreas, gonad, bladder cancers. There's a lot of cancers that can be associated with Peutz-Jeghers. The other one is juvenile polyposis syndrome, okay, which is associated with the SMAD4 gene, whatever. Now, for you to diagnose that this is juvenile polyposis syndrome, there is a cutoff or a few criterias that you need to follow. Number one is going to be the number of polyps, if it's more than 5. If you have any extra colonic polyps, juvenile polyps present, then this could be a sign of juvenile polyposis syndrome. A family history, plus any number of polyps with a family history of juvenile polyposis syndrome. Okay, these are the criterias. You have other ones that's present. Tuberous sclerosis, we've gone through it in other blocks. You have angiomyolipomas that's associated with it, hamartomatous polyps, cerebellar lesions as well, and so on. But it's not too high yield to remember these 3. Okay, these 2 are the most important ones. Okay, you have Cowden, which is associated with benign skin tumors with the hamartomatous polyps. This one, it's not too important, as I said, and so on. Okay, memorize and know these 2. Now, to identify these polyps is very important. What type of polyp is this? Hyperplastic polyp. Excellent, good. So as I said, hyperplastic polyps have a serrated layer, okay? The surface layer is serrated. Serrated just means, as our colleague mentioned, it looks like a cauliflower, which is true. It's basically a knife, okay? It appears just like a knife, okay? So this is what a serrated border is, okay? You can see it goes up, down, up, down. It looks like a knife, okay? So this is a hyperplastic polyp. It's the most common type of polyp, as we mentioned. Now, to differentiate this between this and the sessile serrated polyp, which is a neoplastic polyp, it's dangerous. You look into the glands. If the glands are also serrated, okay, then this is the other type, the more neoplastic type, which is the sessile serrated polyp. Okay, if the only thing that's involved is the surface, this is a hyperplastic polyp. Is this concept clear? Okay. How about this patient? Has many of these polyps, has mucocutaneous pigmentation. What do they have? Peutz-Jeghers syndrome. Perfect, good. So this is Peutz-Jeghers syndrome. As I said, autosomal dominant, LTK gene, association, mucocutaneous pigmentation that's associated, and so on. Okay. Here you have a mixture of smooth muscle with the glands that's not organized. Okay. So that's why we say this is hamartomatous. Okay. This patient, what type of polyp do they have? Juvenile polyps. And I already mentioned what makes it a syndrome, if it's more than 5, if there's extra colonic involvement, if the patient had any number of these polyps plus a family history, then we can say this is juvenile polyposis syndrome. Okay. Anyways, this is basically a mucoid filled cyst that's also in the polyp itself. Okay. Now, the more important ones, which is the more dangerous ones, is the colonic polyps. Colonic polyps that are neoplastic. So you have 2, adenomas, and number 2 is serrated. Okay. Now we'll talk about one by one. Adenomatous polyps arise from mutations in what gene? Number one, I want you guys to tell me what gene. KRAS is involved. But what's the first? P16 is involved. The most important one, beginning. APC. Now, colonic cancers can arise from two different pathways, okay, generally, okay? You have one which is called the chromosomal instability pathway, and the other one is the microsatellite instability pathway, okay? These two polyps are involved in both, okay? So number one is you have a defect in APC. APC is in the chromosomal instability pathway. This later on will form the adenomatous polyp, okay? This mutation, number one, will form an adenomatous polyp. So you have the polyp that starts to form, which is usually pedunculated, and we'll get to a picture of it later. Later on, this polyp will continue to grow. The size is important. It will continue to grow. And then you'll acquire a KRAS gene mutation, okay? Once you have a mutation in KRAS, it will grow even more and more and more and become even more dysplastic. It will lead to high-grade dysplasia. Then the last thing is you have a P53 mutation. The P53 mutation will allow it to become cancerous, okay? This is a chromosomal instability pathway. These three genes start off with the APC gene, which allow it to become a polyp. If it's P16, then correct that, okay? You have P16 as well, but I believe it's P53. Correct me if I'm wrong. You start off with APC, then KRAS, then P53, and then you develop the cancer, okay? Now, these polyps can form sporadically, which on its own, okay, it forms and later on can develop into a cancer, or can be, okay, perfect. Or it could be involved in a syndrome. What is that syndrome? If you have many of these adenomatous polyps, FAP, okay? Familial adenomatous polyposis, okay? So you have these two, tamam? For the structure of these adenomatous polyps is very important. You have three different ways it can, like structures or morphology that it has. Number one is tubular, if it has tubules. Number two is villous. Number three is a mixture of both, which is tubulo-villous pattern. Which one is the most dangerous and associated with the highest risk of malignancy from these three? Villous, okay? Villous pattern has the highest malignant potential, okay? This is APCs. In terms of where in the colon, now where in the colon do the adenomatous polyps form? Usually, left or right? Left, specifically in the rectosigmoid junction, in the rectosigmoid area, okay? Again, make this associated with the cancer, okay? Because usually it will start off this and then develop into cancer, okay? Or associated with the syndrome. The other one is a serrated polyp, which is associated with a defect in the microsatellite instability pattern. That instability pathway is involved with one gene, which is the MLH1 gene. Okay, there's more, MLH2 and so on. Also, these polyps are associated mutations with BRAF, okay? Now, if these serrated polyps with MLH1 mutation is involved in a syndrome, what is that syndrome called? Can develop in the cancer with MLH1 gene mutation. Can be, but hereditary. Good. Okay, I got what you meant. Hereditary non-polyposis colorectal carcinoma or colon cancer. Another name of this is Lynch syndrome. Okay. You need to remember Lynch and FAP, familiar adenomatous polyposis. Okay. Lynch syndrome is associated with MLH1 gene mutation in the microsatellite instability. the reason why I mix between serrated polyps with Lynch syndrome is you can make it a sequence of events and makes it easier for you to memorize it, okay? If you have serrated polyps on its own, it can lead to sporadic cancer. If you have multiple of these polyps, can form into Lynch syndrome or HNPCC because it's the same it's the same mutation in this case, MLH1, okay? Also, where in the colon does HNPCC or Lynch plus the serrated polyps form? Where? Which side of the colon, right or left? Right side, okay? It's also on the right side. Tamam? These are the most important things to remember. Now, what type of polyp is this? Has a stalk. Good, so it's pedunculated. The most common type, it's adenomatous polyp. Good. So this is adenoma. Now, the most important features for you to comment on when you see an adenomatous, what is the most important? You guys have to tell me this one. What is the most important feature that you need to comment on? Size. Okay, the size. The size is super important. Good. There is a cutoff, I think above 2 centimeters has an increased risk by 30%, I believe, to develop cancer. But anyways, the size, that's number one. If it's tubular or villus, villus is worse. The invasion to the stalk, as one of the colleagues mentioned, perfect. And lastly, if it has high-grade dysplasia. By definition, these polyps will have dysplasia, degree of dysplasia. If it's high grade, this is worse. Okay? So that's pretty much it. Now, this one over here, what type is it? Is it tubular or is it villus? Tubular pattern, good. Tubules, okay? This one, villus, okay? Perfect. And that's it. Which one is worse? As we mentioned already multiple times, villus is worse. How about this one? This is the sessile serrated polyp. Good. Okay. Again, it will involve the surface slightly. It's not as apparent as the other image. But anyways, it involves the surface, and you can see a bit here, here, anyways. And it involves the glands itself. It's distorted. Okay. And the other one, if we go all the way back, the glands are circular. It's normal. Okay, this one is only in the surface. This one involves deeper glands. Okay. Now, for the familial syndromes, we've already gone through a lot of this, alhamdulillah. So just to summarize, FAP, familiar adenomatous polyposis, autosomal dominant. It's in the APC gene, okay? And that's pretty much the important things about it. Usually with familiar adenomatous polyposis, they present with hundreds of adenomas. What is the risk that they have to develop cancer? Give me the percentage. 100%. Good. They will 100% develop into colorectal cancer. So what do you recommend these patients to do prophylactically? Remove what? Exactly. Remove the entire colon. Okay. So you do a pancolectomy. Remove the entire colon. Okay. Because they will 100% develop into cancer. So that's what you tell the patients or recommend. You have other mutations. It's not really important. Now for HNPCC, which is Lynch syndrome, it's MSH2, MLH1. Okay. Autosomal dominant. It's on the right side. Okay. And as I said, it's associated with the sessile serrated adenoma because it's the same gene. Okay. Sporadic cancer is the most common cause for cancers. Okay. For colon cancer, it's usually in the APC on the left side. It's associated with the adenoma that we saw. Okay. Sporadic, another way that it can form is sporadic due to the MLH1 gene. It's on the right side, as we mentioned, because of the sessile serrated adenoma. Now, there is two important associations or syndromes associated with familiar adenomatous polyposis. If someone has FAP with bone tumors, osteomas, what do they have? Gardner, good. If someone has CNS tumors, it's Turcot. Okay, that's it. Lynch syndrome, the more important, we already mentioned it in detail already, but Lynch syndrome is associated also with extraintestinal cancers, very importantly to remember, such as endometrial cancer, ovarian cancer, and skin cancer. Okay, uh, we're gonna talk about this inshallah in endorebro. Again, Lynch syndrome will come back then inshallah. تمام. So endometrial, ovarian, and skin cancer. Now, what syndrome does this patient have? Hundreds of polyps everywhere. Familial adenomatous polyposis. Good job. Okay. Again, your recommendation is to remove the entire colon. Now, what did this patient develop from these from these polyps? What did they develop? Cancer. What do we call this sign? Apple core. Good. As we mentioned in the esophageal section, any cancer in the GI majority will have this sign, which is the apple core sign. Okay. Now for colon cancer, there isn't specific images for you to remember for this. It's just it could be appearing as a exophytic polyp, very large polyp or tumor, such as this one over here. It can present like an ulcer and so on. Okay. Usually it's going to be an elderly patient, a patient who has a history of smoking, has history of the polyps, has history of polyp syndromes, IBD, such as ulcerative colitis, most importantly, and so on. The most important or common location for colorectal cancer is going to be in the rectosigmoid junction. So it's going to be most commonly there. Now, in terms of manifestations, sometimes it's going to be asymptomatic. However, if it causes symptoms, it depends on the location. We mentioned this when we talked about the simple anatomy, is if it's on the left side in the rectosigmoid, it's going to be more of obstructive symptoms. Okay. So in this case, you'll have partial obstruction, pain, GI bleed, obviously anemia, weight loss, and so on. But the important differential or difference between the right and left is it's going to be obstructive signs. Okay. The stool, basically the shape of the stool will look like a pencil, very thin. Okay. In the left-sided colon cancer. Right-sided will most likely present with iron deficiency anemia and GI bleed. Okay. Now, diagnosis, you do colonoscopy with biopsy. Okay. And that's pretty much the diagnosis. Then you do a CT, MRI to check the extent of the cancer to stage it. Okay. Now, if you have this patient who has colon cancer and has multiple liver masses, this is metastasis. What is the most common cancer of the liver? Most common metastasis. Okay. Metastasis is the most common liver cancer. Okay. Liver tumor. Okay. Primary liver tumor is different, but most commonly it is metastasis from the colon. Okay. That's pretty much it. You do have a tumor marker in colon cancer, which is this. This is what we call the CA antigen or CA tumor marker, which is called the carcinoembryonic antigen. Okay. This is the tumor marker for this. Okay. Screening usually starts at a patient at the age of 45, and you do it every 10 years. If someone who had a family history of colon cancer, you start 10 years before when their relative developed it. So the relative developed at 55, you start at 45. Okay. Patient with IBD, you start 8 years after they're diagnosed, unless you have a patient with ulcerative with primary sclerosing cholangitis. Then you start immediately at that point. Okay. In terms of histology, not too important. However, you have this pattern, which is what pattern? Signet sign. Okay, mucinous. It's a worser type. Okay. Do you guys have any questions for colon cancer? Or polyps, anything? Is everything clear? What about them? Genes, know the APC gene. Okay. Okay. Know the APC gene very well for the adenomatous polyps and for the familiar adenomatous polyposis, and most common gene associated with sporadic colon cancer. Okay. Uh, I'll get to that question. Then you have for Lynch syndrome and for sess-ulcerated polyp, you have the MLH1 gene, most important. And the Lynch syndrome as well, something I forgot to mention, is associated with this mucinous type, okay, of cancer. Other than that, for genes related, these are the two most important genes, MLH1 and APC, okay? You have others. So for example, sess-ulcerated polyp will have the BRAF gene. The adenomatous polyp will have the KRAS gene as well, and the P16, P53, and so on. Then you have the hamartomatous polyp. You have the LK1 and the STK gene for the hamartomatous for Peutz-Jeghers. These are the most important genes to remember. Okay? Specifically, Lynch syndrome is like it's something he likes to ask about. Okay, Lynch syndrome, what gene, MLH. Okay, know that, but know everything. Just be ready for that question. Okay. Know the shapes of the polyps and what they look like, especially for juvenile. It's very characteristic. Like not all of them will have that cystic feature. Uh, and then no hyperplastic versus sess-ulcerated polyp. Okay. Now for this image, this is the mucinous type. There's a lot of mucin, okay, all over the place. And this is the signet cell. If I could show you one, let me move the chat. This, okay. This is the signet cell. It's worser prognosis. Okay. All good with colon cancer and polyps and everything? We move on. We finished the bulk of this session. Okay. The rest of this session will be all the clinical stuff made simple. Okay. I'm not gonna go a lot detail into them because you don't need to know all the details of it. I'll give you what you need to know. Like it's crucial for your exam. So Tamam, let's start by talking about diverticular diseases. Yes, it's the same as Lynch. It's literally what Lynch syndrome is, and the sess-ulcerated polyp. It's a defect in that pathway. Okay. So now for diverticular diseases. So diverticula, you can differentiate it into two types. You have true diverticulums or diverticulum and false diverticulum. Now, as I mentioned before, is that the bowel will have two borders that's very important. This part over here, let's just imagine that this is the mesentery over here. This part over here is the mesentery. This is going to be the mesenteric border, okay? This over here is the anti-mesenteric border, which is away from the mesentery. Tamam? So, true diverticula typically will involve all layers of the bowel. So the mucosa, submucosa, muscularis, adventitia, okay, or serosa. It will involve all of them. False polyps will involve only the mucosa and the submucosa, okay, or the mucosa only, okay, not all of it. Tamam? Now, its relationship to how it's acquired, okay, so you have two types of diverticula depending on its etiology. You have congenital and you have acquired, okay? Congenital will typically be true diverticula, okay? Acquired will typically be false diverticula. Now, what did we say about the mesentery over here before in the anatomy? Is this over here where you have the blood vessels, the vasa recta, going into the walls of the bowel to supply it. This portion of the bowel is the weakest, okay? So if you have someone who has constipation, an increase in the pressure in the bowel lumen, this can cause an outpouching over here. This is what we call an acquired diverticulum, and it will be in the mesenteric border, okay? This type of polyp is a false diverticulum, okay? It's due to an acquired cause. Typically, it's in the mesenteric border. However, if you have a congenital or something that we call a traction diverticulum, it's usually in the anti-mesenteric border, away from the mesentery. It will involve all the layers of the diverticula, and it's usually due to something pulling on the wall of the bowel over here that's causing the diverticulum. Because there's something outside that's causing pulling of the bowel, it will be all the layers of the bowel. Because imagine that it's just pulling the entire thing like this. Okay? So that's why it's going to be a true diverticulum. The most important cause of true diverticula that I need you guys to remember is Meckel's diverticulum. Okay? That is a cause of a true diverticulum. Meckel's diverticula is congenital. It's going to be in the anti-mesenteric border. It's going to be a true diverticula, and it's a traction diverticulum. Okay? This is the most important cause of true diverticulum. For the false diverticulum, which is going to be in the mesenteric side, it's usually due to pulsion, which is something over here, an increase in pressure that will cause it to bulge out. Okay? This is seen in the esophagus, Zenker's diverticulum. When we go in the colon, this is what's going to cause diverticulosis. Okay? Is that clear? Cool. Now, this is the pathogenesis of diverticula typically. Something pulling on the outside, this is Meckel's diverticulum. This is probably the only true diverticula that you need to know. Okay? In terms of false diverticula, this is where you have diverticulosis due to constipation, increase intracolonic pressure, okay? And poor lifestyle, poor whatever, low fiber diet and so on, cause of constipation, okay? So now, you have this patient who has a diverticula that's involving all layers of the bowel, 2 feet away from the, good, from the ileocecal junction at the anti-mesenteric border. This is the mesenteric. This is the anti-mesenteric. What is this? Meckel's diverticulum. Good. Now, Meckel's diverticulum, how do you remember? What's the rule of Meckel's diverticulum? Rules of two. Okay, here it is. It's 2 times more likely in males, 2 feet, 2 inches long, 2 feet from the ileocecal valve, 2% of the population, the first 2 years of life. And it has 2 types of epithelium. Now, in children, what's the most common presentation of Meckel's diverticulum? Presentation. How do no, Meckel's is congenital. However, it can be diagnosed early, it can be diagnosed late. Okay, but it is congenital. In children, how do they usually present as? Bleeding. Okay. Usually they'll present with painless bleeding and nothing else. Okay. You do further investigations and you'll see a Meckel's diverticulum. In adults, they usually are asymptomatic. Okay. However, if they have symptoms, it's usually either bleeding or obstruction. Okay. So that's how you can tell the two. Usually it will give you the scenario as a child. Okay, as a 2-year-old who presents with painless bleeding. Okay. You further investigate, it's Meckel's diverticulum. What is the congenital defect here? It's basically failure of the allantois, okay, to close. Okay, that's the embryology. Now, for Meckel's diverticulum, it can present as obstruction, can present as a hernia, which is what we call a Litter's hernia. It's not too important to remember that one. And how do you diagnose it? What's the diagnostic test? Michel's scan, which is what? Nuclear scan, good. Which is the technetium 99 per technate, okay? Which is this one. This is high yield. Remember this, okay? Very high yield, okay? So this is Michel's diverticulum. Moving on is that you have this patient over here. Now, where in the bowel are we looking at? Where in the intestine? Which part of the intestine are we looking at? Duodenum. So what type of diverticulum is this? Duodenal diverticulum. Okay, so this is the duodenal diverticulum. As I mentioned, is that duodenal diverticulum, there is one specific type of duodenal diverticulum that I need you to know. A, it's going to be in the second part of the the second part of the duodenum. There's two types. There's going to be intramural, which is within the wall, or extramural. Intramural is by far the most important one to remember. Why? It can obstruct the pancreatic duct and the common bile duct. It can obstruct the sphincter of Oddi and the ampulla vater opening, leading to pancreatitis and bile stasis, which will present as acute cholangitis, jaundice, right upper quadrant pain, and so on. Okay? The triad for that, which we'll get to later. So this is duodenal diverticulum. The most important thing you need to remember is the intramural one will present with these symptoms. Okay. How about this patient? Asymptomatic or has bleeding. Diverticulosis. Good. Diverticulosis, multiple diverticula. Okay. Usually going to be in the mesenteric side because that's where you have the weakening of the bowel wall, usually in a patient with chronic constipation, poor lifestyle, obesity, and so on. Most common presentation is asymptomatic, found incidentally. However, if they have a symptom, what is that symptom? Do you guys know? If they have bleeding, good. The most common cause of lower GI bleed is diverticulosis. Okay, from the lower GI bleed causes. Okay, lower GI causes is diverticulosis. Do you guys know what the second most common cause is? Okay. The second most common cause is angiodysplasia. Okay, it's in the GI bleed lecture and in the miscellaneous large bowel disease lecture. Not important. Okay, just remember the most common cause of lower GI bleed is diverticulosis. Now, this diverticulosis can be complicated. If it gets obstructed and infected, what do we call it? An inflamed, infected. Diverticulitis, good. So diverticulitis will present as left lower quadrant pain, fever, abdominal pain, and so on. Okay. Key thing is left lower quadrant pain as well. Okay. You do so yeah, that's diverticulum. Now to manage diverticula, it's usually surgical or you just wait. Okay. If it's asymptomatic, you don't really do much. For diverticulitis, that's very important. If someone has active diverticulitis, do you do a colonoscopy? Yes or no? No, this is very important. If someone has active diverticulitis, you do not do a colonoscopy. This could lead to perforation and rupture. Okay, it's contraindicated. So usually you just give them antibiotics and this is curative. If they have complications, further complications such as abscess, perforation, so on, this is a surgical management. Okay. Diverticulosis, you usually just try to treat the underlying cause. Constipation, you treat it. If it's asymptomatic, you don't really do much. You can do a colonoscopy in diverticulosis. Okay. Diverticulitis is a no. Okay. How about this patient? What do they have? If you want a case, I'll give you one. But I want you guys to get it from the image. You need to memorize this image. Okay. A child, let's just say 2 years of age, had a recent infection in the GI, later on presents to you with bloody diarrhea, which we call a current jelly stool, has severe abdominal pain, and you do imaging and you see this. What do they have? Okay. So this is intussusception. Okay. What is intussusception? Okay. Intussusception is telescoping, exactly. Telescoping of the bowel, of the proximal bowel into distal. To explain this very quickly, this is the normal bowel, right? When it does peristalsis, usually the proximal will contract and the distal will relax. That's how peristalsis is. So you have this portion of the bowel is contracted, the proximal. This portion is still dilated. Okay, so it will appear like this. In intussusception, there's something called a lead point. A lead point will be somewhere, for example, over here. Okay. Now, what this lead point is most commonly in children, as I mentioned, previous GI infection, they have lymphoid hyperplasia, which is basically the lymphocytes will start to accumulate in that site, will cause slight bowel thickening. Okay. In adults, it's a mass, a polyp or a tumor. So when this part of the bowel is contracting, this part over here, it will have the lead point or the mass. So what will happen if you imagine it is when it contracts, it will tug on this point and go inwards and cause the telescopic. Okay, this is what intussusception is. Okay, in terms of the imaging, the very important sign is this, which is the target sign. Okay, there's many things that has target sign. However, if you have a suspected patient with intussusception, had a mass before that was diagnosed, later on you have GI obstruction, current jelly stool, which is so characteristic of intussusception. You see this target sign? It is intussusception. Okay. Is intussusception clear? Cool. How about this patient? What do you see on imaging, or do they have? Air fluid levels. Excellent. Good. This is the air fluid levels. This is the air, this is the fluid. Okay, this is the bowel. Down. This is obstruction. Where? Is it large bowel or small bowel obstruction? Small bowel obstruction. Good. Now, how would this patient present with? The patient would present with acutely distended bowel, hyperactive bowel. You do auscultation, it will be in the earlier phase, it'll be hyperactive, then it will go down. Okay. The patient will be in distress, could be vomiting, vomiting, hemodynamic instability, tachycardic, tachypneic, and so on. Okay, that's typically how they will present with. Small bowel obstruction will have many causes. There will be intramural cause and extramural. First of all, what is the most common cause of small bowel obstruction? The most common cause. Adhesions, good. How will they give it to you is in the case of small bowel obstruction, the patient will have previous surgery. Okay, had a previous surgical procedure done. So for example, a patient 8 years ago had a cholecystectomy, now has a small bowel obstruction. What is the cause? Adhesion. The most common cause of small bowel obstruction is adhesion. Okay. Later on, in intramural, you have many causes. Intramural or intraluminal causes, sorry. Intraluminal is in the lumen. So you have, for example, a mass, a polyp, a stricture that closes it, something, okay? The more important one, there's bezoar as well, which is basically indigested food or undigestible food that accumulates and forms like a ball. It's a bezoar. Anyways, that's not too important. And a patient with cholecystitis. which is gallbladder inflammation, has cholelithiasis, they can have something that's called a gallstone ileus. A gallstone ileus is basically, this is the gallbladder, okay? This is the bowel, okay? Slowly, because of the inflammation, this part of the gallbladder that's inflamed will form a fistula with the bowel, okay? Okay. And slowly that the stone that's appearing over here will go down and cause obstruction in the terminal ileum because that's the narrowest portion of the small bowel, okay? So it will obstruct there and it will cause small bowel obstruction. We'll get to a separate slide in this, okay? Then extra luminal, which is from the outside, which is very important. You have two. The most common is adhesion, which is from outside, a surgical scar or a surgical, at the surgical site, you might have a fibrous scar formation or fibrous tissue formation, which is the adhesion that forms the obstruction, okay? The other important type is in a patient who lost, an obese patient, you follow them up 6 months later, they lost 70 kgs, present with small bowel obstruction. What do they have? 70 kgs in 6 months. That's crazy. And then has small bowel obstruction. No. They tell you that they lost weight because they went on severe weight loss regimen, not cancer. Loss of the fat pad, you're onto it. Good. No. To give you a clue, the obstruction is at the SMA syndrome. Good, excellent. Okay, at the third part of the duodenum. Why? Is because of the loss of the fat pad. The way I described it is a patient losing 70 kgs. That's usually the number they always use, okay, in any exam, okay? They lost so much weight over a short period of time that the fat pad goes down all the way. So they present with small bowel obstruction, okay? These are the two important causes. Here is SMA syndrome. So between the superior mesenteric artery and the third part of the duodenum, there is a fat pad. When you have a severe weight loss patient who had a lot of weight that they lost, this fat pad can disappear, causing obstruction, okay, of the third part of the duodenum. Again, just remember in the question stem, if they tell you that they lost so much weight in a short period of time, they went on a weight loss regimen, later on presented with bowel obstruction, this is the cause until proven otherwise. Okay? This is clear. I need you guys to remember this. Okay. The other one is in a patient who had cholelithiasis and cholecystitis. Due to the chronic inflammation that's happening, what can happen is that there could be a fistula, which is an abnormal connection between two epithelialized structure. That's a definition of a fistula. So two epithelialized is a bowel, loop bowel in the small intestine with the gallbladder. It forms, okay? When it forms, this forms a cholecysto from the gallbladder, enteric from the small intestine, fistula. This gallstone will go into the bowel, go all the way to the terminal ileum and obstruct there. Terminal ileum is again the narrowest portion of the small intestine. So what will you see on imaging is a characteristic triad called a Wriggler triad. What is this? Is number one, you'll see air fluid levels and signs of small bowel obstruction, such as dilated small bowel and air fluid levels. Number two is very important, something called pneumobilia. Pneumobilia is air in the biliary tract, okay? Why is there air in the biliary tract? The small bowel, the intestine has air. When you have this abnormal connection between the gallbladder and the bowel, the air will go into the gallbladder and then will go on into the biliary tree and air will be present in the biliary tree, okay? Last one, which is not seen in this image actually, is you'll see a stone, okay, in the distal bowel. Tamam? Is gallstone ileus clear? Cool. So this patient, very key image. Like you will get this volvulus. Good, exactly. This is a sigmoid volvulus. A volvulus, I defined it previously as in the gastric volvulus, is basically when you have a bowel, a loop of intestine or a loop of whatever, and stomach even, when it wraps around its own mesentery. Okay. Typically, in an elderly patient, usually they describe it as an elderly patient who is in a shelter, for example, very elderly, presents with bowel obstruction and so on. You do imaging, you see a volvulus. Okay. Now you have multiple types. You have number one, which is based on location. Sigmoid volvulus is most commonly in elderly, and it will appear as a coffee bean sign. Excellent, good. So this is a coffee bean appearance. You have other, such as a cecal or cecum cause, which will be the opposite. It will go from the right to the left. Okay. Then you have the transverse colon, I think is what it's called. It's going to go from up to down. They're not too important for you to identify and to know. The most important is sigmoid volvulus. Okay. Now, lastly is from the obstruction causes. This one is a megacolon. Okay. So megacolon, as I mentioned before, is just basically the colon is big. There's many, many causes. The ones that I want you to know very, very crucially is an UC, an ulcerative colitis, develops toxic megacolon. That's number one. Number two is pseudomembranous colitis, developing C. diff, exactly, developing toxic megacolon as well. Okay, these are the two important causes that I want you to remember. Now, for treatment, management, very generally speaking, when you have a patient with either small or large bowel obstruction, okay, the first thing you need to do is you stabilize the patient. What does that mean? Is you give them IV fluids. You do not want to give them anything in the mouth. Good, non-peroral, NPO. You want to keep them NPO because you don't want to put more food into them and it causes more obstruction. Okay, self-explanatory. Because you're giving them NPO, you want to give them IV fluids, okay? Because you want to give them parenteral nutrition as well. You want to give them IV analgesics. You want to give them IV antiemetics if they're vomiting. Okay, everything IV. And you want to do, excellent, a nasogastric tube. Why? Is you want to decompress. If there's obstruction and there's fluid accumulation or food accumulation, you put an NG tube, you go all the way down and you suck the food out. Okay, this will decrease the amount of obstruction. Okay. Now, and then you relieve the obstruction. It's usually surgical. Okay, you go in, you remove what's causing the obstruction. Adhesion, you cut the adhesion. Gallstone ileus, remove the gallstone. If it's let's just say bezoar, you remove that as well. Okay, polyp mass, you remove it. Okay, so surgical. For a volvulus, there is a next step in management, which is basically you put a tube, a colonoscopy. Okay, you do a colonoscopy or a sigmoidoscopy, and you decompress it manually through the scope. Okay. Later on, because this part of the bowel is not viable usually anymore, you resect it. Okay, later on, and you do something called a stoma, which is basically a bag. Okay, connected to outside, which is a stool bag. Okay. You don't need to go into the intricate details of it, okay, of what do we do, what procedure, or any of this. Just know that usually in small bowel obstruction, you treat them conservatively in the beginning. You stabilize, give fluids, nasogastric tube, IV fluids, antiemetics, antipyretics, pain, keep them non-peroral, and so on. Then later on, once they're stable, you relieve the obstruction surgically usually. Now, one subset of patients will have something called paralytic ileus, which is a non-obstructive cause of small bowel obstruction. The bowel walls are just dilated and there's obstruction, but there's nothing causing obstruction. So basically the bowel walls are not motile enough. Usually this happens post-surgically, okay, because you give anesthetics, which will slow down the bowel, okay? There is one drug I want you guys to memorize, okay, to treat non-obstructive causes of obstruction or non-anatomical causes of obstruction, which is neostigmine. Okay, just memorize this drug. Okay, it's the opposite. Usually, when you give anesthetics, you give muscarinic antagonist. So neostigmine will inhibit the acetylcholinesterase, exactly, which will increase the amount of acetylcholine, which will make the bowel more motile. Okay, excellent, good. So that's it. Is this clear for bowel obstruction? Do you want me to repeat? No, you don't. Usually they'll give you a scenario of someone who has UC, ulcerative colitis, later out complication, or C. diff. Then you'll know that this is megacolon. Okay. Transverse volvulus is very low yield, very low yield. Okay. If you guys need me to repeat anything, as I said, let me know. Okay. Next topic. Okay, we're gonna go. We actually don't have a lot left, alhamdulillah, and the time is pretty good. But anyways, next thing is mesenteric ischemia. Okay, mesenteric ischemia can be divided into, depending on where. Okay, so mesenteric, we usually refer to it as the small bowel ischemia. Colonic ischemia is the colon. Okay, so for mesenteric ischemia, generally, you have two classifications, either acute or chronic. Okay, talking about chronic first. Chronic is usually due to what underlying disease that the patient has. What can cause chronic mesenteric ischemia? Atherosclerosis. Good. So it's usually atherosclerosis. Patient who has atherosclerosis had a coronary artery syndrome, peripheral vascular disease. They might have a chronic mesenteric ischemia because of atherosclerosis. And this is typically in the superior mesenteric artery. They will have atherosclerosis, which leads to narrowing of the artery. Okay. How would they present with is this is a more chronic disease. They will present it with it over time. Usually, this will present as something that we call intestinal angina. Okay, that's what we call it. What is that intestinal angina? Is basically after they eat, they will present with abdominal pain. Why is that so? It's because when you're eating, to digest food, you need adequate blood supply. So the blood supply to the bowel when you're eating will increase. Okay. With someone who has atherosclerosis of the intestinal arteries, of the small mesenteric artery, the superior mesenteric artery, sorry, the amount of blood supply going to the bowel when it needs the blood supply is less. So it will cause chronic mesenteric ischemia, postprandial after meal pain. Okay. Usually in a patient with chronic atherosclerosis. So they will have other signs of atherosclerosis. Okay. That is chronic mesenteric ischemia. Acute mesenteric ischemia most commonly is due to either embolic or thrombotic occlusion. In a patient who had chronic mesenteric ischemia, suddenly has severe pain, not related to food, this is because of acute thrombotic occlusion. Why is that so? If you remember from CVP, when you have an atherosclerotic plaque, one of the complications that can happen from the atherosclerotic plaque is thrombosis of this plaque. Okay? So with thrombosis, they will present acutely with severe pain. Embolic, it's usually in a patient with atrial fibrillation or with signs of mitral stenosis, had previous rheumatic heart disease. Why? Because the left atrium will enlarge. Anyways, they are predisposed to embolism. So either this is embolic stroke, embolism into the lower limbs, to the renal arteries, splenic, everywhere, okay? Usually in a patient with atrial fibrillation. Anyways, one of the areas that can get the embolic, destinations is the bowel, okay, the superior mesenteric artery. This will present as an embolic acute mesenteric ischemia. There are other, such as veno-occlusive, not too important. Non-occlusive, we'll talk about it more in the colonic ischemia. And strangulating bowel obstruction, not too important. The most important is the arterial occlusive. How will they present with is very important. Is what we call pain out of proportion of examination. Okay? Pain out of proportion. What does that mean? Is they will tell you that this pain is so bad. It's 10 out of 10, very, 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 very severe. When you do physical examination, you don't really find much. Okay? So this is what we call pain out of proportion. Okay? This is a key sign of acute mesenteric ischemia. Okay, you do physical exam, you don't find anything. You try to elicit pain, it's not as bad. However, they will tell you that I have pain just resting. I have so much pain. Okay? This is acute mesenteric ischemia. Chronic mesenteric ischemia is intestinal angina. Every time I eat, afterwards I get pain. Okay? Only after I eat. You take further history. Oh, I had a coronary artery. I have coronary artery disease. I have peripheral vascular disease. Signs of atherosclerosis. Okay? Is mesenteric ischemia clear? These two causes. Cool. Now you have non-occlusive mesenteric ischemia. Non-occlusive is more important when we talk about colonic ischemia. We've already talked about this in the anatomy portion. It's in a patient who had hypovolemia, hemorrhagic shock, severe hemorrhage, or undergoing a very cardiovascular intensive procedure. So, for example, a AAA, aortic aneurysm repair, good. Abdominal aortic aneurysm repair. You need to clamp arteries. The most prone areas to ischemia are the watershed areas in the colon. Two areas, the splenic flexure and the rectosigmoid junction. These two areas have the weakest blood supply because it's at the watershed, which is basically the distal portion of two blood supplies, okay? It's far less than the rest of the colon, like in terms of the blood supply. These two areas are most prone. So you have colonic ischemia, okay? So this is what non-occlusive mesenteric ischemia is. In a case, they typically describe it as a patient undergoing AAA abdominal aortic aneurysm repair, later on had abdominal distension, abdominal pain, and so on, bloody diarrhea. This is a sign of colonic ischemia. Okay? This is basically mesenteric ischemia. What imaging modality will you use to assess patients with mesenteric ischemia? CT, good. CT what? It's not just CT. CT angio, perfect, good. Now, in CT angio, you'll see this. Do you need to differentiate the two? I don't think so, okay, whether it's thrombotic or embolic. To explain it, this is the aorta, okay? This is this superior mesenteric artery in both of them, okay? This is the superior mesenteric artery. This is the rest of the aorta, okay, abdominal aorta. Now, in the abdominal aorta, you can see severe calcifications. So this might be a patient with atherosclerosis, which might deviate you from saying, oh, this is embolic, right? But the way that you can tell is, firstly, look at the superior mesenteric artery. This is the proximal opening. It's all clear until the distal. Okay, that's number one. Number two, in this patient, you'll see the extensive calcification in the superior mesenteric artery. Okay, so this is telling you this patient has severe atherosclerosis in the intestinal arteries. Okay, then here you have this portion of here, which is where you have the thrombosis. To tell the two apart more specifically is that in a patient with thrombotic mesenteric ischemia, it will be in the proximal part of the superior mesenteric artery. Proximal, in the upper portion near the opening. In embolic, it will be more distally. Why would it be more distally? The distal portion is more narrower. So it will go all the way through the proximal to the distal. Okay, because it's an embolic. Do you need to know the difference? I don't think so, but that's an explanation for you guys. Okay. Treating it is not important for you guys to know. Okay. Now, You have the same patient with mesenteric ischemia. They have this sign. What is this sign called? It's not specific for intestinal ischemia, but could be seen. Good job. Okay, good. Pneumatosis intestinalis. Okay. Not too specific, but basically it just means that there's air in the bowel wall. Okay. Again, it's not too specific, but you might see it in an OSPE question or in a MCQ as a hint. Okay. So now you know what this is. This is seen in bowel mesenteric ischemia, not too specific. It's basically the necrotic walls because of the less blood supply. There are other causes. When you go into fourth year, you'll know them. Okay, inshallah. But for your level now, this is all you need to know. The last thing of the small and large bowel before we go very quickly to the next few sections is short bowel syndrome. Short bowel syndrome is defined as functional small bowel length below 200 centimeters. The key term I put here is functional, okay? So it does not just mean that the bowel length is short, it's just that you don't have that much bowel. It also refers to as the functional bowel, how much of the function is retained in the small bowel. So if you have a patient with Crohn's disease, extensive colitis, extensive inflammation of the small bowel, someone with severe celiac disease, they won't have enough of the small bowel length, so they will have short bowel syndrome. In another case, a patient with extensive Crohn's disease, you did so much surgical resection that the remaining bowel is 150 centimeters. This is what we also call short bowel syndrome, okay? With short bowel syndrome, the more important thing is it causes nutritional deficiencies, obviously, because you lose the absorptive capacity of the bowel. Okay, that's number one. You have nutritional deficiencies. Vitamin B12, fat-soluble enzyme, vitamins, sorry, such as A, D, E, K, and so on. Okay, vitamin D. Okay, these are the important deficiencies that you'll have. Okay, in terms of nutritional deficiencies. The other thing is if you have a disease that's causing damage to the terminal ileum. Now, the two things that they can form is two stones, gallstones and kidney stones. What type of kidney stone will they develop if you guys know? In any patient with small bowel, excellent, good. Calcium oxalate. Why? Especially in patients with Crohn's disease, what happens is this. The terminal ileum is the source of most of the lipids absorption, the fat-soluble vitamins, the what's it called? The bile salts. Okay, you have the enterohepatic circulation of the bile salts in this section of the terminal ileum. Now, if you have loss of function of the terminal ileum, such as in a patient with Crohn's disease, what happens is this. Firstly, let's talk about the bile. Okay, the enterohepatic circulation is less. Because of this, you have a washout of the bile salts. So the liver is going to look at this and say, okay, there's an imbalance between the cholesterol and the bile salts. I need to fix this somehow. But it's not going to fix it perfectly. So it's going to increase everything, especially cholesterol. Cholesterol synthesis will go up. So it will form what with increased cholesterol synthesis? What's the complication? Cholesterol gallstones. Excellent. Good. So they will present with cholelithiasis, cholecystitis, and so on. Okay? Because of this cholesterol increase. The other thing is because you don't have fats being absorbed, what happens is this. If you have a patient with fat malabsorption, so yeah, fat malabsorption, and any cause of fat malabsorption, what happens normally is this. So calcium, usually in the bowel, will bind to oxalate. Okay, and this will decrease the amount of oxalate being absorbed. Okay, this is normal. In a patient with fat malabsorption, you will have less of the what's it called, fat being absorbed. So this excess fat will bind the calcium, leaving oxalate free. It's not going to bind to calcium anymore because the fat is binding to calcium. So the oxalate is just going to get reabsorbed, go into the blood, go to the kidney, and form a stone. This is what we called an oxalate stone or calcium oxalate stone because of the excess oxalate. You guys need to know these two, okay? The gallstones and the kidney stones. You need to know that it happens in small bowel syndromes or short bowel syndrome, specifically if it affects the terminal ileum, okay? Now, for management of patients with short bowel syndrome, it's typically you have acute and maintenance, okay? Acute, you give them parenteral nutrition. You give them TPN, try to restore their nutritional status, okay, number one. Maintenance is you try to basically not make them deficient in the minerals and vitamins. So you give them minerals and vitamins in the maintenance therapy. Okay, that's literally all that you need to know for short bowel syndrome. Which concludes small and large bowel. You guys need me to repeat anything, go back, questions, anything? Okay. So the next sections is far shorter, okay, than the small and large bowel. So we'll go through them quickly. The first one is appendix. Very easy. There's only two things that I want you to, one thing mainly to remember. This is the appendix. It's at the base of, it's near the cecum, okay? It's connected to the cecum. To identify it, as I said, you have the Taenia coli, you have three. You go and follow it until you find the base of the appendix, which is this. This is the tip of the appendix, okay? In terms of the layers, you can say that this is a true diverticulum. Why? Because it has mucosa, submucosa, and muscularis, all layers, okay? For function-wise, it has just lymphoid follicles. So it has some immune function, okay? That's pretty much it. The most important pathology in appendix is acute appendicitis, okay? You have cancers that develop and so on. It's just not too important. For the positions of the appendix, you have many. The most common is what? What position of the appendix is the most common from all of these? Retrocecal, excellent, which is this. What's important about the position of the appendix is the clinical signs and symptoms of appendicitis. It could be different if someone has a pelvic versus retrocecal, okay? The key symptoms that we're going to talk about and the signs is because of retrocecal position. For example, the position of the psoas muscle and so on, okay? So now you have a patient with appendicitis or suspected appendicitis. What happened? So firstly, they have obstruction. In an elderly patient, what is the most common cause of obstruction of the appendix? There could be neoplasm, but a bit more common. Let's just say someone who has constipation and their stool became very hard. The stool itself, okay? So the stool can obstruct it. This is what we call a fecalith, okay? Fecalith. A fecalith is basically a very hardened piece of stool that obstructs the opening of the appendix. The other thing is in children more commonly is lymphoid hyperplasia. As we said, the appendix has lymphoid tissue. If the patient had, if the child had infection, this hyperplasia will thicken and will cause the obstruction, okay? What will this obstruction cause? Increase in intraluminal pressure, which will basically cause a stasis of fluids, and a stasis of fluid is always going to allow bacteria to grow. Now, for bacteria, what is the most common bacterial cause of appendicitis? E. coli, good. Give me two more common ones. Klebsiella, good. One more. Pseudomonas. Memorize these three, okay? E. coli, Klebsiella, Pseudomonas, okay? These are the three bacteria that can cause appendicitis, okay? Then you have more pressure distension, which will allow venous compression because the venous walls, the veins, have a very thin walls and doesn't have musculature, so it can be easily compressible. So when this compresses, it will cause outflow obstruction, which will allow blood to just stay there, which will then lead to ischemia. Okay. With ischemia, you have arterial compression. Okay. So how will this patient present with in terms of appendicitis? Where will the pain start? Will it start in the umbilical or in the right lower quadrant? Periumbilical. It usually starts periumbilical, then moves to the right lower quadrant. Okay. The periumbilical is due to referred pain. Okay. And then it moves to the right lower quadrant. Okay. So that's the pain of appendix. This is a very key sign of appendicitis that usually we'll see. They can present with nausea, vomiting, fever, okay, and so on. Now, I'll tell you physical signs, and you tell me what that physical sign is called, okay? So first of all, I'm going to press at the right lower quadrant and press on it, and it produces pain. Where is this pain located? McBurney's point. Excellent. Now, at the same area, I'm going to press and release. And when I release, it causes severe pain. What is that sign called? Rebound tenderness. Good. I'm going to move to the opposite side, the left lower quadrant, and I'm going to press and release, and it causes severe pain. What is the sign called? In the left lower quadrant. And the pain is in the right lower quadrant. You guys know. Good. Robsing sign. Okay. Then there's two related to movement. Okay. If I flex my hip joint or extend it, sorry, move it backwards, and it causes severe pain, what is this called? Psoas sign. Okay, if I extend my hip all the way back, okay, this is psoas sign. If I flex my hip, I said flex in the beginning, then I changed to extended. If I flex my hip, then rotate it, okay, this is obturator sign. Okay, these are the signs that you need to know. Now, the more important thing is what do you do to diagnose it? Firstly, is clinical and history and so on. That's like usually enough. However, if you were to do imaging, what is the gold standard imaging? You can start with ultrasound and you can use ultrasound in specific, but it's CT. Okay. Ultrasound in specific groups of patients. So for example, pregnant and children use ultrasound. CT is the best modality to use. Okay. Because if you have a patient who's obese and so on, you can't really see anything with ultrasound. Okay, that's why the best is CT. Okay. So in either cases, what you see is you see that the lumen is narrowed in the appendix. This is the appendix. The walls are thickened. And you might have periappendiceal fat. I can't really see it here. And edema that's around the appendix. Here you can see that clearly this is a fecalith. Okay, that's causing the obstruction. This is the appendix. It's very big, distended appendix. Okay. Anyways, and you can see it here as well. So, you could probably see it in the ultrasound, but it's not, we don't really typically call it a target sign. Okay. You comment on the size of the appendix, you comment on the wall thickness and the lumen, okay? That's usually what the clinicians and surgeons do when they see the appendix. They don't just call it a target sign, okay? There are cutoffs to the length and to the size of the walls and so on, okay? Now, for appendix, what is the management? Basic management of appendix. What is the best management for appendix? Resect it, surgery. Okay, that's typically what you need to know. Is an appendectomy. You remove the appendix. Okay, there are multiple different types. There's something called interval appendectomy. You don't really need to know them, صراحة. But if you have a patient who has a tumor in the base of the appendix that's very large. It's more than 5 centimeters. You usually need to resect the appendix with the bowel, okay, with the right colon, okay. This is what we call a hemicolectomy, okay. This is the only other thing you can do. I don't think you need to know the details of them. Saraha, just know that the management of appendicitis is surgical. If the patient is not showing signs of complications, you can wait within 24 hours and do it. But usually you just do the surgery anyways. There is one complication of appendicitis, which is appendiceal abscess. Now, for abscess, usually you have to drain the abscess, okay? So with that also, there are, for example, if it's less than 5 centimeters, more than 5 centimeters, again, you don't really need to know it. If they have an abscess, you drain the abscess, okay? That's basically the basic treatment of appendicitis, okay? Now, for tumors and pathology, again, not too important. What does this patient have? They had appendiceal, exactly. Okay, pseudomyxoma peritonitis. They had an appendiceal mass. Later on, they see that it's seeding the mesentery. Okay, this is what we call pseudomyxoma peritonitis, where you have mucinous mass or tumor that then seeds the peritoneum. Okay, the mentum. So this is what we call pseudomyxoma peritonitis. Not too important. This one in the tip of the appendix, mucocele. Okay, what is the most common tumor of the appendix? Malignancy is adenocarcinoma, but usually carcinoid is very common. Okay, carcinoid in the appendix is very, very common. Okay, and that is appendix. Any question? Or is everything clear? It's very short. The most important thing to remember about appendicitis is just appendicitis. Okay, you know how to diagnose that this is appendicitis. Know the symptoms that are present in the appendicitis. Okay. In elderly, you suspect cancer. You might suspect cancer in a patient with appendicitis, but usually it's benign. You remove the appendix, you're good. Okay. Now, anorectal is mostly me explaining, because honestly, it's very low yield and very advanced for you guys to know. Okay. There's not too much for you guys. Like, I don't think you'll get a lot of questions. However, if you do get any questions, it's probably going to be a hemorrhoid or a fissure. Okay. So now, in terms of the anatomy of the anal canal, the important anatomy, anatomically, the anal canal will start over here, which is the dentate line or the pectinate line. Below that is the anal canal, typically. However, surgically, we want to talk about the anal canal, we start over here and move down. Why? Is because certain pathologies will appear above the pectinate line or the dentate line, and it's important to differentiate the two. What's important to differentiate between the two is above the pectinate line or the dentate line, the type of epithelium is different. The epithelium is the glandular columnar epithelium that's in the rest of the GI, okay? The blood supply of this area is coming from the inferior mesenteric artery. The blood supply is, the venous drainage is portal circulation, okay? This part of the anal canal is visceral, like the nerve supply is visceral, okay? So you won't feel pain. If there's anything over here, you won't feel pain, okay? So this is the important parts of it. Below the dentate line, the epithelium will be squamous epithelium, okay? The blood supply will be from the internal pudendal artery. The venous drainage will be from the systemic circulation. So it will be, for example, from the internal pudendal vein, the internal iliac vein, and so on. Okay. And then the nerve supply will be somatic. So you will feel pain, okay? The other thing is that in these things over here are called the, what's it called? They're called the columns of Morgagni. These columns will have openings of glands, okay, of ducts. These glands are called the cryptic glands. This is important when we talk about the anorectal spaces, because anything that causes obstruction to these crypts and these glands will cause fluid accumulation, which will later form an abscess, okay? Where will this abscess form? In the anorectal spaces that we're going to talk about, okay? Then you have these distended veins. These distended veins, if there's anything causes chronic constipation, can bulge out. It can bulge out either above the dentate line or below the dentate line. If it's above the dentate line, if there's bulging veins above the dentate line, what do we call this? Internal hemorrhoids, okay? If it's below the dentate line, external hemorrhoids. There are ways to differentiate the two that are more important, and we'll get to that. Tamam? This is the important parts of the anal canal anatomy, okay? And now we come to here. As I said, that these columns of Morgagni will have these openings to these glands. These glands, okay, are called the cryptic glands. These will have a connection to some spaces, which we call the anorectal spaces. You have 4, okay? Let's start with the closest one, is this, which is the perianal space, okay? That's number 1. This one, you have here the internal sphincter, okay? This is the external sphincter. So this is in between. The space is in between the sphincter, so we call it intersphincteric. It's between the 2 sphincters, okay? Then this part over here is right external or lateral to the external sphincter, so we call it the ischioanal. It's near the ischium, the bone. So that's why we call it ischioanal space. Then above everything is what we call supralevator, which is this one. Okay. Again, if you have anything causing obstruction to these glands, it can accumulate fluid in these 4 spaces, in any of these 4, causing an abscess. Okay, it's what we call anorectal abscess. Okay, we'll get to a separate slide on this. Now, hemorrhoids. Hemorrhoids, you have 2 types. You have internal hemorrhoids and you have external hemorrhoids. Internal hemorrhoids will appear above the dentate line. So because of this, will the patient have pain? Yes or no? No, because the nerve supply is visceral. It's not somatic. It's not like the skin. It's like the normal GI nerve supply. So it's visceral. You won't feel pain, okay? There's no such thing as visceral pain in this case, okay? So internal hemorrhoids will typically present as a painless rectal bleeding, okay? The patient will tell you, I have constipation, okay, or signs of constipation. That's the risk factor in this case, for internal hemorrhoids, is constipation, okay? And then you have the causes of constipation: poor lifestyle, obesity, low fiber diet, low fluid intake, and so on and so forth. Okay, so that's internal hemorrhoids. The same risk factors can be applied to external hemorrhoids. External hemorrhoids are below the dentate line. So do they have pain? Yes or no? Yes, and this is severe, severe pain. Okay? Very severe pain. They can present with bleeding. Yes, like sometimes yes or no, especially if it's thrombose, can be very, very severe pain. Okay? Now, to classify hemorrhoids, you have 4 classifications for internal hemorrhoids, okay? I don't know if this is important for you guys to remember, but it's just important for the management of these hemorrhoids. But basically, internal hemorrhoids, you can't see them, okay? So you do an anoscope, which is you're looking into the anus, and then you see it. This is stage 1 or grade 1, okay? Grade 2 is you ask the patient to strain, which is the Valsalva maneuver. It will protrude, okay? When it protrudes outwards, and then you tell them to stop straining, it moves back inside on its own. This is stage 2. If you ask the patient to strain and it does not move back, except if you use your finger and you manually reduce it, it's a stage 3. Stage 4 is it won't reduce. It will appear outwards, okay? This is the classification for internal hemorrhoids. Management of hemorrhoids, the most important thing is the first line management is lifestyle, okay? You give them analgesics, local anesthetics in this area. You tell them to do sitz baths. You relieve the constipation. If this doesn't work for internal hemorrhoids, you can do office procedures. So for example, you can do banding. You put a band around it, you tie it, and allow this hemorrhoid to fall off on its own, okay? You basically cut off the blood supply to it, okay? This is only for internal. Why don't we do it for external, this band procedure? If you guys know, just for the concept. Pain, it's very painful. External is very painful. So imagine you put a band around it and you allow it to die. A patient will scream. It's super painful, okay? So for both internal, external, the first thing you do is lifestyle, okay? You do conservative management, which is basically painkillers, sitz baths, relieve the obstructive constipation that they have, and then maybe it relieves, okay? Less straining when you use the bathroom and so on. The office-based procedures such as banding, photocoagulation, cryotherapy, and so on, you do it for internal hemorrhoids. It's first line for grade 3, and if the grade 1, grade 2 failed by lifestyle modification conservative, you do it. You don't do it for external. If external hemorrhoids, if it did not get relieved by the lifestyle and the conservative management, then you do surgical removal of the hemorrhoid by, under general anesthesia, okay? Or if all the hemorrhoids, if it failed conservative for internal hemorrhoids, if it failed the office procedure, you can do surgery, okay? That's typically all you need to know for hemorrhoid in terms of the management. Again, you start off with lifestyle. External hemorrhoids, you do not do office procedure, okay? If lifestyle failed and conservative, you move straight to surgery, okay? That's the high yield points. Start lifestyle, start conservative, move to either office for internal, surgery, first line for external if the conservative fails. This patient over here tells you, I have very severe pain, perianal pain, and whenever they wipe after their stool, they see fresh streaks of blood. What does this patient have? Anal fissure, good. The way I described it just now, which is the severe pain whenever they go to the bathroom, followed up by when they wipe, they see the bleeding, the blood. This is a key description of an anal fissure, okay? Again, a history of constipation is typically the cause. The first line management of patients with anal fissure is you do conservative, okay? You give them painkillers, relieve the constipation. Typically, they respond to this. If it didn't work, you do surgical. The name of the surgery is not too important, okay? But basically, you cut the sphincter in the bottom to relieve the pressure, okay? Because it's usually due to excessive straining. Now, anorectal abscess. Again, as I said, it forms in any of these spaces that we talked about. Supralevator, perianal, intersphincteric, ischoanal, okay, or ischiorectal, okay? Due to obstruction of the crypt glands that drains into these areas, okay? Causes, there's many, not too important to remember all of them at all. Maybe poor anal hygiene and so on, patients with AIDS, HIV, IBD, okay, and so on, can have this, okay? Not too important. They may present with fever. They feel a mass presence in the perianal region. They might have perianal itching as well, but again, it's not too important for anorectal abscess. A sequela, or what's after anorectal abscess, is they might form an anorectal fistula, which is again a connection between two epithelialized structures. So in this case, it's with the anal canal or the upper part of the, or in the rectum in this case. It forms a abnormal connection with the skin. Okay, so you'll have an external opening and you'll have an internal opening. The classification that we have for anorectal fistula is something called the Parkes classification, which there's 4 types: intersphincteric, transsphincteric, extra, and supra. You don't need to know this, I don't think so, okay? But basically, transsphincteric is it goes through the 2 sphincters, the internal and external sphincter. Intersphincteric, there's an internal opening, goes through the internal sphincter, and then goes out. It does not go through the external sphincter. That's how you can tell that these 2 apart. Suprasphincteric, somehow, it goes through the internal sphincter, goes up, then goes out. Okay. Supralevator, or sorry, extrasphincteric, sorry, it does not involve the 2 sphincters. These are very confusing points for you guys at your level. Just remember that the cause of this is usually after an anorectal abscess. They might form a fistula. Another important cause is Crohn's disease. Okay, this is another important cause for anorectal fistula. What will they present with is usually they will find fluid draining out of these openings. Okay, presenting with pain in this area in the perianal area, itching because of this fluid that irritates the skin, and so on. Okay. Management is you try to close this fistula. Okay. You close this fistula, you can open the fistula now to heal, okay, on its own as well. There's a name for this procedure, fistulotomy. Okay. You open it and you allow it to heal. You can put a sort of a thread into the fistula and allow it to heal that way, okay? Which is what we call a ceton, okay? But you don't need to remember that. This is basically all you need to know for fistulas. It's a bit too advanced. Just know that this classification exists, the Parkes classification. There's 4 types: intersphincteric, transsphincteric, supra, and extra, okay? I think the most common one is intersphincteric. I believe so, but double check on that. Okay, that's pretty much it for anorectal fistulas. What does this patient have? Rectal prolapse. Excellent. So this prolapse, how can you tell this is a prolapse versus a hemorrhoid, which is what this is you'll have concentric circumferential rings. Okay, this is the way that you could tell that this is a rectal prolapse. Usually it will be in a patient who is it's a female after multiple pregnancies. This is a typical demographic that's affected by prolapse. Okay, female after multiple pregnancies and childbirth. Okay, because of weakness of the pelvic floor. Okay, that's all you need to remember for rectal prolapse. Do you guys have any questions for the anorectal diseases and want me to repeat anything? Or is all good? Tamam. The last slide, literally the last slide, is hernias. You guys had the lecture on Tuesday, okay? I believe so, if I'm not wrong, because I had to move the lecture, the session to today. That's why I couldn't do it Tuesday, because of this lecture. Anyways, hernias. Hernias is an outpouching of basically peritoneum plus associated viscous or organs or bowel through a defect, usually in the abdominal wall. Okay, that's how we define hernias. There are many types of hernias, okay? But I don't like there's so many, but I want you guys to master these 3. Let us do some let's draw actually. Okay, so I'm gonna draw this, which is a muscle. Okay, I'm gonna draw this, which is a ligament, and then take blue as blood vessels. Okay, So I'm gonna have one going down here, and then I'm gonna just keep it like this for now. Tamam? Okay. So you have two types of hernias that's affecting the inguinal region. Then you'll have another one that's going to be below this ligament, which is the inguinal ligament. Okay. So this is the inguinal ligament. This is the rectus abdominis muscle. And this is the epigastric vessels. Okay. Just take it as two vessels. Okay. It's artery and vein. Anyways, there's two vessels over here. The important thing about this is its relationship. Where do these hernias develop? Okay. And through what structures do they develop? This is the most important thing about these hernias. Now, you have two types of hernias affecting these two regions. Something called indirect inguinal and something called direct inguinal hernias, okay? If you have a hernia that's developing this side over here, lateral to the epigastric veins or epigastric vessels, which type of hernia is this? Is it indirect or direct? If it's lateral to the epigastric vessels. The other one. Indirect, okay? This is indirect. Indirect is lateral to the epigastric vessels. Medial to it, this is medial, this is lateral. Medial to it is direct, okay? So this is how you tell the difference between them. This is the most important way. The other thing is, where do these hernias go through? The first one is indirect inguinal hernia, okay, which will go through all the rings, the deep inguinal ring and the superficial inguinal ring, go all the way to the scrotum, okay? The cause of indirect inguinal hernia is usually it's a congenital cause due to persistent processus vaginalis, which didn't fail to close. Usually the process vaginalis, if you remember from the scrotum, from the testes, it'll go from the posterior abdominal wall, goes through the inguinal canal and inguinal ring, and goes to the scrotum. While it's doing that, it pulls part of the peritoneum with it, which is the processus vaginalis, and later it closes. Okay, if this persists, it will form a hernia, which is indirect inguinal hernia. There is another pathology that also presents due to persistent processus vaginalis. It's when you have fluid accumulation in the scrotum. It's called a hydrocele, if you remember from renal. The way you differentiate it is you put a light. If it transluminates, it's a hydrocele. If it doesn't, it's a hernia. Okay. So that's usually the cause of this. Okay. It follows the whole direct path of the testes. Goes through the deep inguinal ring, through the inguinal canal, and through the superficial inguinal ring to the scrotum. It will form lateral to the epigastric vessels. This is very important, okay? Direct hernia will skip through the deep inguinal ring. It'll go directly through the superficial inguinal ring. So it'll ignore the deep inguinal ring, go through the superficial inguinal ring. That's why we say it's a direct hernia. It will directly go through the superficial inguinal ring and herniate, okay? It will be medial to the epigastric vessels. It will the reason why you have direct inguinal hernia is due to a muscular defect, a muscular weakness. Where is this muscular weakness? It's a weakness in the transversalis fascia. Where is this fascia? Here you have a triangle. I'm gonna change the color. Okay. Let's go with this. So here you have a triangle. Okay. Well, do you guys know what this triangle is called? Hasselbalch's triangle. Good. So the Hasselbalch's triangle is formed by these three borders. Medially, you'll have the lateral border of the rectus abdominis. Okay. Laterally, you'll have the epigastric vessels, and then forming the floor, not the floor, the inferior border, it's a triangle, inferior border is the inguinal ligament. Okay. This is the Hasselbalch's triangle. The floor of it is formed by the transversalis fascia. If you have a weakness of this transversalis fascia, a hernia can develop in it, which is the direct inguinal hernia. Typically, it's an adult patient that did extensive exercise and straining, and then it developed. Okay. Now, the last type of hernia from these is the femoral hernia. Femoral hernia, there will be another vein over here that's very important, which is the femoral vein, which is the most medial out of all the structures between the below the inguinal ligament, which is what? Nerve, artery, vein, and lymphatics. Okay. This is going to be very medial from these three. Ignore lymphatics. No one cares. Anyways, the femoral vein. This type of hernia will develop medial to the femoral vein. This is an important area for it. It will present below the inguinal ligament, medial to the femoral vein. This is most commonly in females, okay? Most commonly in females. Females will have femoral hernias more than males, okay? Now, important things now, important concept. Do you guys get these three hernias well? Or do you want me to repeat? Okay. Now, what is the most common hernia from these three? Most common in both males and females. Yes, exactly. The most common hernia from these three is an indirect inguinal hernia. Memorize this. The most common is the indirect inguinal hernia. This is the most common. Okay. Now, in terms of how these hernias will present, there are some terms that I want to mention to you guys. First of all, is something called reproducibility. Okay. How will this form, or how will this present? Is you ask the patient to strain. Valsalva maneuver, you increase intra-abdominal pressure. This loop of bowel, the hernia, will herniate. Okay, it will herniate outwards. Then you ask the patient to stop. It will go back. Okay, so it will move backwards. At the same time, is if you ask them to Valsalva, it will herniate outwards. You can reproduce it manually. Okay, and it will go back in. This is what we call reproducibility. However, if you ask if patient presents with a hernia like this, and you try to reproduce it, it can't reproduce. It can't reduce, sorry. It can't move backwards. This is what we call an incarcerated hernia. Okay? If it cannot move backwards anymore. This is what we call incarcerated. If this loop of bowel obstructs the rest of the bowel, this is what we call obstructive. And the last thing is strangulated hernia is if we cut off the blood supply to this hernia and this portion will be infarcted. Again, if you ask the patient to do the Valsalva, to strain, it herniates, then you reproduce it manually, or they stop straining, it goes back. This is reproducible hernia. If it can't move back and it's persistently herniating, this is what we call incarcerated. If it causes GI obstruction, this is obstructed. If the blood supply cuts off, this is what we say is strangulated bowel, a strangulated hernia. Strangulation, incarceration, and obstruction is an emergency. Okay? You need to do surgery. The management of hernias in general is surgical. You need to remove the hernia. Okay? You need to surgically relieve the hernia. Tamam. Now, from these three, the most commonly to present with strangulation, with incarceration, is the femoral hernia. Okay? I think that's it. Annie, that's the more high-yield facts about the hernias that you need to know. Okay? What do you mean? So sliding hernia is in the esophagus, mostly. That's when we say this is a sliding hernia. You don't need to know any. Sliding hernia is important when we spoke about it in terms of hiatal hernias. Okay, it's a type 1 hernia. Okay, over there. From these three, from the abdominal hernias and the groinal hernias, these three are the most important ones. There are so many other ones. There's umbilical hernia, salpingian hernia, Litter's hernia. There's a lot, okay? Dude, like it's very, very low yield, the other ones. Like that's why I doubt it will come. That's why I will not go through. Okay. These are the more high yield ones. This is what you need to know for your exam. Most likely you'll get one question. Someone who has a hernia lateral to the epigastric vessels, what hernia do they have? Okay. Indirect inguinal. This is how the question will be. A female who has a hernia below the inguinal ligament, medial to the femoral vein, what type of hernia do they have? Femoral. Okay. It's typically going to be questioned like this. Okay. With that, I conclude this part of the crash course.
Thank you,
Do you,
Fawaz.
anytime. Do you guys have any questions? Is everything clear?